help if I had a microphone. Good afternoon, everyone. Can I welcome members, invited guests, officers, and the public to this meeting of the Health Committee. Please may I remind participants to turn your devices off or put them on silent. Today's meeting is to discuss the Health Inequalities Strategy Implementation Plan 2021 to 2024. We encourage anyone taking part in the discussion on social media to use the hashtag #AssemblyHealth. And can I now ask our clerk, Diane Richards, to confirm any apologies for today's meeting?
Thank you, Chair. No apologies for absence have been received. Assembly Member Boff will be in attendance remotely in accordance with Standing Order 2.4.
Thank you. And can I ask members to note the list of offices set out at item 2 of the agenda and ask if members have any other interests to declare?
Noted.
Thank
No
you.
interest to declare.
Can I ask the committee to confirm the minutes of the meeting held on the 13th of January 2022?
Confirmed.
Thank you. And can we note the completed and ongoing actions arising from our previous meetings?
Noted.
Thank you. And I'd just like to take this moment to thank everyone in the scrutiny team and also the comms team for the work they've done helping us with our output, Trans Health Matters, Improving Access to Healthcare for Trans and Gender Diverse Londoners, that was published yesterday. So thank you to all of you. And can I ask members to note the responses from the Mayor of London and the Secretary of State for Levelling Up, Housing and Communities to the committee's The Toilet Paper report? So, before we begin our main discussion today, I would like to invite London's Public Health Regional Director, Professor Kevin Fenton, CBE, to provide a quick public health update to the committee in light of the lifting of COVID measures last week. So, Kevin, over to you.
Great. Thank you very much, Chair, and good afternoon, colleagues. We are at an important and pivotal time in the COVID-19 pandemic, both in our country and in our city. As the government announced last week the lifting of COVID-19 restrictions in light of the reduction in case rates as well as reducing hospitalizations for COVID-19, it does signal clearly that we're now in the decline phase of the pandemic in the city and in our country. Over the past 3 months, the city has managed its way through the Omicron wave. We have seen throughout the course of this wave significant increases in rates of infection, a near 15-fold increase from mid-November to the beginning of January of this year. Associated with those rapid increases in the Omicron variant, we saw increases in hospitalizations as well as significant outbreaks within our care homes and other settings. The burden of Omicron was perhaps somewhat mitigated in the city compared with waves 1 and 2 by virtue of the relatively high rates of COVID vaccination levels which we now have in the city as a result of the successful implementation of the COVID vaccine program over the past year. And in addition, what we believe is a significantly higher population exposure to COVID throughout all phases of the pandemic, experienced by many Londoners. So that higher level of population immunity or population exposure to the virus would have helped in part to mitigate the impact of the Omicron wave. Today, overall infection rates in the city are just above 350 per 100,000. We see some variation across our boroughs in the city, but I'm pleased to report to the committee that all boroughs are experiencing robust declines in rates of infection, and we're seeing this consistent in those aged over 60, as well as in young people in the city. So we're seeing consistency in case rate reductions across a range of demographic characteristics. Now, in addition, we are also seeing more objective reductions in prevalence of infection as measured by the ONS survey. And this gives us the confidence that we are truly seeing reductions in levels of infection. And these are not merely an artifact of changing testing behaviors as a result of changing government policy on testing for the coronavirus. Now, as we move towards living with COVID, as articulated by the government, London partners have been working together to identify core priorities for us to ensure and assure that we are focused on the key things to exit this wave of the pandemic safely. The 7 key priorities that London's partners are working on are as follows. Number 1, protecting the most vulnerable through vaccination and access to antivirals. 2, continuing our work on culturally competent messaging to reinforce public behaviors and engagement on the COVID-19 pandemic. 3, to work with national government to ensure that there is access to sufficient and free testing to high-risk individuals, those who are clinically exceedingly vulnerable, as well as key workers who may be at exceptionally high risk. 4, ensuring that we're working with the UK HSA and government partners to ensure an effective regional surveillance and early warning system remains in place for the region. 5thly, to work with our communities and local government to work to reduce the known and exacerbated health inequalities. And the final 2 priorities for us in this phase of the pandemic will be monitoring and maintaining support for infection control in the highest risk settings, including hospital and care home settings. And finally, ensuring that we work with local authorities and directors of public health to ensure our ability to scale up and respond quickly and rapidly in event of a new variant or localized outbreaks. So, Chair, on that basis, I'd conclude my review of where we are with the pandemic and also my initial reflections on living with COVID and what it would mean for our city. Thank you.
Thank you very much. And that those 7 points for us to be thinking about for London as we exit that previous stage of the pandemic is very reassuring. That it's got that you mention kind of keep that forward scanning to check that there is that there's not a new variant turning up, and also all the measures that you've put in. I'm sure all the committee will agree that we are reassured by the way that it is looking to address inequality and to keep Londoners safe. So thank you very much for that update. We now that brings us to our main item, and I'd like to extend a warm welcome to our guests today, joining us to discuss the Health Inequalities Strategy Implementation Plan 2021 to 24. So we have Jazz Bogle, who is the Assistant Director of Health, Education and Youth at the GLA, and of course we also have Professor Kevin Fenton, CBE, who is the Regional Director for London Office of Health Improvement and Disparities and the Statutory Health Advisor to the GLA. So welcome to both of you. We're also expecting Dr. Tom Coffey, OBE, who is the Mayoral Health Advisor, who will be joining us at approximately 3 o'clock. So that brings us to our questions, and I'm going to start with our first section of questions is just looking overall at the health implementation plan. And my first question is for Kevin. Kevin, there are around 200 commitments in the latest Health Inequalities Strategy Implementation Plan. So we'd like to know what mechanisms and metrics are in place to track the progress against all of those, and also just to understand whether you think it's realistic to deliver against such a large number of commitments.
So thank you very much for this initial question. And I'd like to begin by just framing the importance of the health inequalities strategy for London as we exit from and emerge from this phase of the COVID-19 pandemic, in which throughout the pandemic, the light that has been shone on inequalities is undeniable, and the pervasive nature of these inequalities and the fact that many of them have been exacerbated is also quite clear to all of us working across the London system. The health inequalities strategy is bold and comprehensive, and by virtue of covering quite a number of key priority areas, it necessarily means that we have identified a number of performance indicators as well as key indicators to monitor our progress moving forward. I'd also like to remind the committee that the activities and the commitments within the plan not only reflect the commitments of the GLA, but also wider partners across the London landscape. So whether working on healthy children, healthy minds, healthy places, healthy communities, or healthy living, the range of partners, including local government, the Office of Health Improvement and Disparities, UCSA, the NHS, and the GLA are all contributing a range of activities on the plan. And that results, therefore, in a number of core indicators that are being committed to. Now, to prioritize and focus our efforts on what really matters to ensure we're moving in the right direction, each of the core themes within the health inequality strategy has articulated a single ambition and has identified a key commitment that will galvanize partners and will keep the focus overall in terms of the range of activities on what we think are the most important things that need to be measured to demonstrate forward movement and progress. So, as an example, for a healthy children theme, we know that the ambition there is to ensure that London's children eat better and families will find it easier to eat healthy food. Our commitment is around the initial ambition of up to 50 school super zones supported by 2025. And that gives us a sense of a totemic commitment that will galvanize the system, but supported by a range of other performance measures as well. So I'll pause there, Chair, to give a sense of both the complexity of the HIS, but also the importance of using a range of indicators for different stakeholders, but galvanized by an overarching commitment in the strategy. Thank you.
Thank you. Can I just ask what so you've given a good sense of the the sort of the key commitment decision about what the most important thing to measure is. I'm still slightly kind of wondering how you're managing the scale of this, because there's so many different partners and people that you're working with. I just wonder if there's just anything extra you can just say on that.
Absolutely. So one of the great things about the health inequalities strategy, and as the public health director, I was very keen that we not only have concrete performance indicators and commitments, but we have the governance in place to oversee and to track both the commitments as well as the indicators. So very briefly, just to highlight the governance that we have in place. At the most proximal level is the Health Equity Group, which is a subgroup of the London Health Board. It's chaired by myself and Will Tuckley, who is the Chief Executive of Tower Hamlets. The Health Equity Group had the overarching responsibility for overseeing the development of the HIS and is taking an active role in the implementation of the HIS and ensuring that there's forward progress on all of the core commitments as well as the major themes. And in the Health Equity Group, we have been working closely to ensure that the agendas are formatted so that we're reflecting on and tracking the progress in the various sections of the HIS. Now, in addition to the Health Equity Group, we also have the Health Equity Delivery Group, which is chaired by the NHS and by colleagues in ADPH. And that provides oversight into the NHS health equity commitments, which are articulated in the plan, as well as a range of other health equity priorities for the NHS. And again, that group oversees and tracks the progress against those commitments in the NHS. Finally, other governance bodies which we report into, which also have an active interest in our progress, include the London Health Board, and we have an ongoing regular update to the Health Board, which provides a progress on all of the core themes, as well as the recovery missions and the recovery board, which also provides the other sort of governance framework for this. So again, in addition to the key performance indicators, the overall commitments, we now have a robust governance in place to drive and to assure ourselves of progress in these domains. Thank you.
Thank you. That's really helpful to understand that, yeah, that's much clearer, certainly in my head. My next question, again, Kevin, for you. The GLA Health and Wellbeing team has been allocated £739,000 to deliver the Health Inequalities programme between 2021 and 2024. So how much funding is being made available across the wider GLA group to deliver the health inequality strategy and all the commitments in the implementation plan? So that's the stuff that's outside of the 739,000.
Mm-hmm. So I think you have correctly identified, and it's really important that we view the funding for the health inequality strategy as not only residing in the health and well-being group, but by virtue of the GLA's commitment to health in all policies, there are commitments from across the GLA and the group towards health inequalities. The figures which I have here, just as a top-line indication, and we'd be very happy to follow up with more detail to the committee, would be that most of the health team's work currently is in fact focused on health inequalities, and in 22-23 the budget was 4.5 million. And this included nearly £1 million on super zones and 420,000 on his implementation work with stakeholders. I'll defer to Jazz to see if you'd like to add any more detail to that, but we'd be happy to follow up with the committee on budgetary detail.
Thank you. And good afternoon, committee. Thank you for having me. To add to Kevin's points, I think it's important to kind of note that tackling health inequalities and the objectives of the health inequality strategy don't just live within the part of the team that is called the health inequality strategy team. So as Kevin said, kind of tackling health inequalities is a foundational objective, pretty much everything we're doing, and not just across health. And so it's important to note also that other resources that will be in relation to other programs of work that actually are seen as kind of, for example, some active travel work that TfL colleagues will be doing, or work that MOPAC is doing to tackle violent crime. These are all objectives that will kind of contribute to the global delivery of his objectives and most of these KPIs. So this is the resource that we've allocated here is actually about us being able to mobilise that wider resource and take that health in all policies approach much more broadly. In addition to that, what we are going to be doing is to look at creating a new public health function that would go group-wide, and I know that's something that you'd like to ask questions on later, so we can come on to that later if that's helpful. But I think kind of this is really about mobilising the breadth of work that can be done across taking a health in all policies approach across the GLA group to really look at how we can maximise that much bigger impact that we could be making.
Thank you. So that 739,000 is like a sort of mobilising fund to kind of make sure that the other parts of the GLA are doing the work that's required to deliver.
Yeah, to some degree, but also about, and partners, so not just the GLA group. So I think, for example, some of the work that we've previously funded and we would want to continue to looking at how we support might be around social prescribing. So this is a way in which kind of we can work with the NHS to look at how they can get much broader support for their patients, where their patients need help beyond medical and healthcare services. And might need access, for example, to support in the voluntary sector or so on. So I think this is kind of an example of where we've got the opportunity to really try and create that kind of capacity in the system, and how we're working with partners to jointly fund or to create the new ideas for what we could be doing. So this money, yes, in some ways it's about mobilising what we can be doing with others' budgets across the GLA group, but also looking at how we can be more creative and kind of push the boundaries on what we potentially can be doing. And working a lot with kind of some of our wider partners, and most of those actually, kind of all of them in fact, and more being representative on the health equity group, and certainly working with some world experts, not just kind of UK experts, but, you know, for example, the team at the Michael Marmot leads at UCL and others who are giving us phenomenal advice on that. Some of the other work that we will do about bringing some of those partners together in workshops and looking at how we're able to kind of create the communities of practice that we're going to need that are enabling some of that work to kind of happen at the ground, really. And I think kind of the big focus for us is about how we mobilise action at a community level in the places where people live, and tackling and targeting those areas where the inequalities are greatest.
Thank you. That's very clear. Now, my next question is a very brief question. It's just a point of clarification. So this implementation plan is 2021 to 24, and we just literally wondered, is that like financial year, so to sort of April 2024, or is it to the very end of 2024? So it's literally a practical question.
I suppose a practical response is a mayoral term, I suppose, is kind of the yeah. The
okay, response. Thank you very much. So that's May. That's very useful. I'm now going to hand over to my colleague, Assembly Member Best, for the next questions.
Thanks, Chair. I suppose in that last answer, that clarifies the question that I just wanted to ask, which was all the 200 commitments to be achieved by the end of the mayoral term.
We will certainly be working towards achieving as many as we can. We recognise that a number of them are complex, and as we are emerging from the pandemic, that we are going to be faced with a range of challenges, both with many of our delivery partners, in terms of the funding environment, new priorities which may emerge, and of course the ways in which we're going to be engaging with Londoners and communities as well as part of this journey. So this is why we have a robust governance infrastructure in place to keep track. We'll be looking at annual reporting, so that annual reports are provided and publicly available to track and reflect on our progress. And we'll be looking at keeping that resolute focus on some of the top-level commitments, which I mentioned earlier as well.
So how many commitments would you consider it a success to achieve if you're looking back in May 2024?
I don't want to be held to a numerical target. I think what I'd be keen to see are three things. First, definite forward movement in as many of our core indicators as we can. Second, a deeper mobilization of our partners as a result of participating in the Health Inequalities Strategy Implementation Program. So we have broader engagement of a range of partners that are acting together. And then thirdly, looking at our community mobilization in this space as well. So yes, we'll be looking at forward progress in our commitments, especially in our overarching commitments and targets, but it's almost a deeper engagement that we're wanting to see over the next 3 years. I'm mindful as well, Assembly Member, that for many public health targets, as you know, the changes that we're expecting to see often take some time as well. So we'll be looking at some short-term gains, but really laying the foundation for longer-term progress as well.
Thank you. On the other end of that, some of the key targets in the 2018 to 2020 plan were met very early. So almost at the other end of that, are you happy that all these targets are ambitious enough? Having pored over them and worked with the team, I think they are. They represent a mixture of challenging targets, but also some which we think are, while not saying low-hanging fruit, they are certainly indicators which can enable us to mobilize action across our partners and to demonstrate forward motion. One of the things that we're grappling with in tackling health inequalities is that we're doing so within a highly complex environment. There's no, as you know, no one single driver of the health inequalities. So it does require action at multiple fronts, by multiple partners acting in an aligned format, in an aligned way. And that's what the Health Inequalities Strategy is enabling us to do. So that's the ethos behind this work and why the sort of partnership work that we've mentioned is so important.
Thanks. I guess coming back to that first bit about some of those key commitments, they specify deadlines beyond the implementation's plan's lifespan. So where that is the case and where those targets won't be met before the May 2024, what are those? What's the interim targets, or how will you be measuring and monitoring progress of success? And again, how will you measure the success up to that point, and then how will you measure the success beyond that point?
So a number of our targets go beyond the 2024-25 period. But if we look, for example, at the air quality, the Healthy Places target, which really has a bold ambition for London being net zero carbon city by 2030 and to be the cleanest air of any major world city by 2050. Those are targets that go beyond the 3-year period. So what we'll be looking at are some of the core indicators on air quality to demonstrate forward movement and year-on-year progress. At the end of the 3-year period of this strategy, we will be working, I presume, with the new administration or with the next administration to ensure that both the statutory responsibility for developing the Health Inequalities Strategy remains in place, and as the statutory health advisor to work with the administration to develop that strategy and ensure we have bold interim targets in place to get us to our 2025 and 2050 targets. So again, what we're laying here are both the overarching direction of travel and annual targets through our performance indicators that we'll be measuring and monitoring. And that's an example from Healthy Places, but it obtains for all of the other themes as well.
Thanks. And where those interim targets will be in place, will those be shared widely?
Well, as I mentioned, we'll be doing an annual report. So that will provide a key progress update on how we're getting on with all of the core themes, a number of our core indicators, and those indicators have been chosen because they're robust, they're available using public data sets, and can be reported on an annual basis. So it is our commitment to provide the annual report, and you'll be able to see how we're progressing with those core indicators. And that will be a chance for us to reflect on what's working, what's not working, and what we may need to enhance in terms of our focus.
Great, thanks. And Chair, I may wish to come in if Onka's questions don't answer a question I have, if that's okay.
So if I can bring in Dr. Onka Sahota.
Thank you, Chair. Cabinet, yes, good afternoon.
Good afternoon.
One of the things, of course, is when this HAS was written up, it was pre-pandemic. None of us knew what was going to happen. But so how adoptable is the Health and Inequality Strategy and the implementation plan so that they can respond to the changes in London's health priorities? How responsive is the HIS to that?
Thank you, Assembly Member. The work on this Health Inequality Strategy actually began in summer of last year after the mayoral election. And it really enabled us, therefore, to build into the development of the strategy, the learning from the first year and a half of the pandemic. Some of the deep understanding that we now have in terms of the pervasive nature of the inequalities, the importance of community-centered approaches to tackling the pandemic, the importance of the vaccination program and the NHS's role in addressing inequalities, but also the comprehensive nature of all partners being aligned in thinking about and committing to tackling health inequalities. And finally, one of the key lessons, I think, from the pandemic has certainly been the importance of tackling structural and systemic inequalities and discrimination. And I'm really pleased that this Health Inequalities Strategy has such a strong and visible focus on structural racism and the role that all partners in the health and care system and broader London partners can and should be doing in terms of tackling those structural issues which drive inequalities. So I'm really pleased that by virtue of having developed the strategy in the past 9 months, we've been able to be agile and to build in the lessons of the pandemic into this.
That's very reassuring. And how does the Mayor address the areas of inequalities that aren't included in the health inequality strategy? For example, trans health.
Yeah. So, one of the things about all strategies is that we try to be comprehensive, but there are going to be new issues which emerge, new priorities and imperatives that we need to integrate and to reflect on. And I know that this committee has taken a very strong interest, and rightly so, on trans health issues. As the Mayor's, one of the co-chairs of the Mayor's Fast Track Cities initiative for HIV prevention in London, we're very much aware of the importance of trans health, as well as the importance of dealing with the health and well-being of all key populations. So specifically, we'd be very happy to work with the committee to understand how some of the core principles of the HIS may be applied to address some of the pervasive health inequalities challenges faced by trans and trans people. And very happy to look at the recent results of your investigation into this to see how we may support the implementation of those recommendations.
Thank you. And how do you see the implementation plan working alongside the government's levelling up white paper and its mission to increase the health expectancy by 5 years by 2030?
So I'm very excited about the alignment between the health inequality strategy and the levelling up. One of the benefits I have working as not only the Mayor's Statutory Health Advisor, but as the Regional Director of the new Office of Health Improvement and Disparities in the Department of Health and Social Care, is that I get to interface with my regional public health director colleagues from across the country. And London's leadership and governance and commitment to health inequalities really stands apart from what other regions have been able to accomplish so far. So I think this really puts us in a very good place to think about some of the intersections with the Levelling Up white paper, to think of what we do as part of the HIS in terms of supporting communities, how we leverage new investments through the Levelling Up white paper and new initiatives, to think about how that may help some of our community-centered approaches, but also align those investments along some of the core themes that we have in the HIS. But it's also bidirectional too, Assembly Member, because we're learning lots of lessons in our implementation of HIS, how we've designed it, that we've been able to inform our colleagues in DLUC and the Department of Health in how we address inequalities. So I'm hoping that as we are now poised to begin reflecting on the implementation of the Levelling Up white paper, that our experience here in London on addressing inequalities will be able to put our city in a very good place for implementation.
Yeah, yes. Professor Fenton, of course, London isn't a homogeneous city. It's a city of great variation. For example, that at the top of the scale, the life expectancy of a woman living in Westminster is 87 years old. And the lowest point of life expectancy of a man living in Dagenham is 78. And yet the government's funding for Dagenham will be £3.93 per head from the first round of the government's Levelling Up Fund, whilst the wealthier Bromsgrove, with a higher male expectancy of 81 years, will receive £148 per head. How do you see this government policy helping us deliver in London the levelling up?
So, I can't comment on government policy and how funding formulas result in allocations to regions, but what I can say is the importance of whatever allocations we have to be able to use those allocations as effectively as possible. And what we have in the HIS, as I mentioned earlier, is an alignment of what we, as partners working across the city, feel are the most important things we need to invest in to help to reduce the inequalities which have widened over the course of the pandemic, and to ensure that we put our region on a stronger footing moving forwards. So I think while the advocacy for resources will sit necessarily within a sort of political domain, as a person who is charged with policy development and program implementation, it is my responsibility, working with partners in the GLA or directors of public health, local authorities, to make the best use of those resources. And, you know, the initiatives here that we have in the strategy, we worked with partners, we worked so closely with our local authority partners, the NHS, to really articulate the things which are most important and to check these with our communities to ensure we're on the right track. So I'm hoping that as the resources from the Levelling Up white paper become available to the city, we can move faster and move towards implementing, greater implementation with those resources. So I think that's my reflection on where we are with this. It's about being poised to act cohesively for impact. And I think our HIS allows us to do that.
One of course, concerns I do, and I say this speaks to as a practicing doctor, right, who's been in the NHS for 30 years, that this inequalities of funding that comes from government, right, in different parts of London. For example, I work in London of Ealing, which doesn't do as very well as compared to Westminster and Richmond, right? There are inequalities of funding, and somehow we do need to raise those concerns, right? That if you want to level up people, those people with the most inequalities need more resources put into them, and unless some of that voice is raised, right? Maybe that's a voice I should be raising, but I need help from people like you, Professor Fenton, to make that voice being heard, that those inequalities need to be addressed. The other thing I want to pick up on is how will the new GLA public health function help to deliver the implementation plan?
Yes, I'd like to put my initial reflections on that, and then I'd like to ask my colleague Jazz to respond as well. As you know, as the Mayor's Statutory Health Advisor, I have a very close link with the health team in the GLA. And since starting my role, I think the value add of the health team has proven itself repeatedly as we've gone through the course of the pandemic, both in its ability to brief all parts of the GLA and the Mayor, to really focus the GLA on the most important health inequalities, health equity, and health priorities for Londoners, and to be a strong systems partner in the city, working with the NHS, previously Public Health England, but now UXA and OHID, local government and other key partners. So emerging from the pandemic, we now have a chance to strengthen that health function in a number of ways. Number one, ensuring that we have more public health capacity in terms of technical capacity available to provide more support and to provide stronger partnership with the different departments within the GLA and different groups within the GLA. Second, to ensure that we are strengthening the support that we have to deliver on both the health inequalities strategy, the various missions which are health related, and of course the London vision for the London Health and Care Partnership, as well as the core functions, health functions, which are articulated in our plans. And then thirdly, by working closely with ourselves in OHID and the NHS and really operating in systems leadership for public health in the city to ensure that the scarce public health resource that we have operates more effectively. The final thing that I'm really excited about for the new public health collaboration is the strong focus that we now have on health in all policies for the GLA and the group. And what this does is that it formalizes the somewhat informal relationships and partnerships that we had previously, which were effective, but we are now ensuring that these are both right-sized and resourced and prioritized in terms of prioritized action to go even further. And so for all four of those functions, from partnerships, systems leadership, program delivery, and health in all policies, the new public health function, I think, is extremely exciting. So Jazz, I'm going to invite you to say a little bit more about the collaboration.
Sure, no, absolutely. I mean, it's important to remember the GLA Act, where it's Section 4 of the GLA Act, is where the role of kind of health sits. And since the Act was first inspired, it did include the creation of a statutory health advisor and a deputy to the statutory health advisor. And to cover the remit of the GLA group, not just the GLA itself as an agency, including obviously yourselves as the Assembly. And I think that kind of realisation of taking that broader view was very much in the aspiration. And certainly when I joined the GLA in July 2019, it was kind of already a conversation that was beginning to be remembered and thought of. So I think that's worth kind of saying. And I think that kind of health in all policies approach, realising that actually the health in all policies has got to be across the breadth of what the Mayor is delivering. And the wider impacts, I think, are really clear to see. A good example, of course, is for example, with air quality and through planning, we know that we can make massive strides in improving health outcomes. We already have seen that now with TfL, with the recent publication of the evaluation of that with the ad ban. So these are agencies that without a kind of, they've all benefited, by the way, from having technical public health expertise, but done on a ad hoc basis and done without the kind of organisation and kind of structure that we think that the now kind of public health collaboration work can now start delivering. So the creation of a public health group, a group function, based within the GLA, needs to be anchored somewhere, but actually making sure that that's a function that's built on public health technical expertise that can really drive and kind of make those changes more systematically. And it's important to say, so the design work that's already underway in the creation and kind of the design of the team is very much alongside, it aligns with the chapters in the HIS. So the new public health function will be designed around the delivery of the HIS, and the HIS will be the kind of, I suppose, the kind of guiding kind of strategic objective, if you like, of the team, bearing in mind that much of the HIS will be delivered through the group as well as that wider partnership. The alignment then with the core, I suppose, public health and well-being, sorry, not public health, the health and well-being team that's based and remains within the GLA is something that we are really looking forward to. I think that's going to be a really good kind of opportunity to get that clarity of work across the GLA group, and then that more focused work on delivery of kind of those wider programs of work that will happen within the GLA kind of core team. And it's probably worth also saying that the ambition here is to extend what we've seen in the last 2 years by having public health expertise and growing the kind of public health capacity within the GLA has enabled us to be far more responsive within the pandemic. So actually the kind of role that Vicky and the other public health consultants have played in supporting the GLA, the Mayor and that wider system to understand its contribution and the role it should take through the biggest health protection emergency we've seen for a generation, I think has given us a much stronger reason, in addition to having that broader, more kind of HIS delivery function.
Thank you. I mean, I actually welcome this initiative, and for all the reasons you allude to. Thank you very much.
Thank you, Onka. I'm just going to briefly bring Assemblymember Best back in before I bring in Assemblymember Harani.
Thank you. And I'll be try and be brief, but just to make one point, I think it's always worth reflecting when we talk about levelling up funding that that London does get the highest per head spending of any English region, and actually has over £2,000 more per head than people in Bromsgrove. So it's always worth bearing that in mind before we make comments like the previous Assembly member. And just, I wanted to ask really quickly, you covered in that question how when the Health Committee brings something up that might not be in the implementation plan, how you might work with us to do that. But how about when the Mayor goes in a separate direction to what is in the implementation plan? And I think specifically here, for example, about the Drugs Commission, which has got a massive impact on health and is one of the biggest conversations in London for health. So where that's not necessarily covered in the implementation plan, actually has a massive impact in health inequalities. And if that becomes a main plank of what the Mayor wants to achieve, then how does that get brought into the work that of the implementation plan?
May I just clarify, Assembly Member, you're speaking about alcohol and drugs as a programme of work in terms of drug treatment and therapy and rehabilitation services?
I don't know, because the Drugs Commission hasn't been. We know it's coming, but we don't know the outcomes it will reach. However, the outcomes it does reach, I should imagine, would have some big impacts on health and health inequalities. So it would make sense, therefore, that those outcomes were laced into the implementation plan on health inequalities.
So I would like to get back to you on this. I know that the London Drugs Commission will involve independent experts looking at the effectiveness of drug laws. It will not look at the classification of Class A drugs. I think I'm still waiting to see further detail on the Commission's terms of reference and, of course, its areas of focus. So I'd rather get back to you on this. If that's
if it's helpful, the idea wasn't to catch up on what the specifics of that. It's just an example of where the Mayor may decide there's a big health issue he now wants to tackle, which is a pivotal to his administration? How does that then feed into this so we can then monitor it? Sorry.
No.
An example was meant to be helpful, not
No.
misleading. Sorry.
No. Thank you for clarifying. Well, in that case, I can respond to that. I mean, absolutely. As I said, the HIS is not meant to be set in concrete. It has to be agile because we cannot say what are some of the new challenges which may come in the short or medium term. And a really good example of this, as well as the Drugs Commission, is what's happening now in Ukraine and what may be the impact on London as a system, the health and care system, as we prepare to receive asylum seekers and refugees from that part of the world. So the HIS provides us with a framework through which we can look at new policies, new approaches, new programs, and say, actually, if you're going to do this well and minimize inequalities, then here are some principles that you need to look at. How do you think about your policies through the prism of healthy places, healthy communities, the things that you need to do to support some of the structural drivers of inequalities? So that's how I think the HIS will be able to be agile. And as I mentioned earlier with the trans health issues, as and when we have new directions or new ambitions for the city, I'm really keen that we work with the health team to support them as well. So thanks.
Okay. Sorry for the confusion again.
That's okay.
Thank you. I'll now bring in Assemblymember Hirani, who is going to take us into our next section, which is looking at healthy places. We've got two sections on healthy places, but this is the first set of healthy places questions.
Thank you, Chair, and thank you for your attendance at committee today. So firstly, just focusing on the air quality side, and maybe to Professor Kevin Fenton to start off with. So how will the impact of improved air quality on health inequalities be measured and evidenced? And what metrics will be used to measure the impact of improved air quality on Londoners' health?
So I'm going to ask my colleagues in the GLA to start off on this one, only because of their proximity to the programmatic indicators, and then I'd be happy to reflect on some of the measurements and the ways in which we're going to be doing that. Okay.
Thank you. So to answer your questions, so you ask about the key indicators that will be used to measure equality. So these are the ones that we currently use, the WHO targets, and so really we'd be looking at the interim target, and now I have to understand. You have to forgive me. I'm not au fait with the technicalities of the indicators, but I think the kind of the line is that by 2030, the aim is for London to be net zero carbon city, and I think kind of the measures for that will be the ones around the WHO's target. The interim target that they have is PM 2.5, which I believe is that particulate matter. So particulate matter percent in airs to 2030 by that time. And I think the kind of wider actions that we are looking to take, and so the reasons why, we know that London's air pollution contributes to over 4,000 premature deaths a year. So that's kind of 61,000 years of life lost. And that sort of, those figures are in themselves really, really hard to hear, I think. And in a city like London that is kind of powerhouse of the country, it really needs to be very, very different. We're making huge improvements between 2016 and 2019. We saw a 22% reduction in NO2 levels, and what we've seen is that particulates are still a problem. So that PM number is still quite tough to change, and we've seen a bigger effect in the inner London areas than to the outer London areas. For that change, and that's something that we're really looking at understanding more. We've put, there's £150,000 that's being put together into a joint programme of work with health and care partners to dedicate a programme that's kind of a programme of work that will be supporting the wider work, which is the Green New Deal. So the Green New Deal is the recovery mission that's funded to £54 million that will be looking at a whole range of programmes that will contribute to this. And then the progress, really, it's kind of using that NO2 level and the PM metrics to understand where we are against that delivery.
Yeah, just to say, thank you very much, Jazz. So the two core indicators are PM2.5 and nitrous dioxide. And these are going to be KPIs that we will track on an annual basis. We have fairly high quality data and quite granular data on these indicators. So we'll be able to look at them not only at the regional level, but at borough level and of course hyperlocal levels. And as Jazz has mentioned, it really allows us to look at where we see persistent and pervasive exceedances for these indicators across the city. And a key part of our approach to tackling air pollution is the combination of both universal approaches, which allows for us to manage particulate matter pollution through traffic, the ULEZ, for example, which are universal measures, but also combining that with more targeted and local measures which can be used to reduce particulate matter and nitrous dioxide in particular high-risk areas. So those are the two key indicators and how we intend to use them moving forward.
It's interesting you mentioned ULEZ, because I know, Jazz, I think in one of your previous answers you talked about health in all policies, and obviously that's an example of transport policies obviously having a positive impact on air quality and lung health and Londoners as well. Just in terms of the TfL situation, obviously there's the funding that you're providing through this section, but actually TfL's lack of capital and revenue funding going forward, particularly over the pandemic, means that I think certain investments in policies like ULEZ may be slowing forthcoming or may not be coming at all. How much of a danger do you see that in terms of improving London's air quality in general? And who do you feel are the other delivery partners in making sure that we're ensure that this strand of the health inequality strategy is successful?
Mm-hmm. Well, as you know, we are waiting for the final settlement from government for TfL. And as we await that settlement, it will have an impact on our ability to plan for, as you mentioned, the expansion of the ULEZs, the further ability to go further and faster with greening of the bus fleet, making other sort of investments into the infrastructure required to accelerate our progress on tackling air pollution. It may also have an impact on our ability to fund and support some of the active travel programs. And I know that a key part of what we're trying to do, not only in tackling air quality, but to ensure that Londoners are healthier and more physically active, is in fact looking at our active travel plans, and TfL is also awaiting the settlement to determine the nature, scale and impact of that plan as well. So as we await, I think there are things that we can continue to do with partners. Last week, the Mayor held an Air Quality and Health Summit, which brought partners from not only across London, but national and international partners, the WHO, to really raise the call on the importance of air quality and health, and to align health and community partners on what more needs to be done. And that's a great example of actions that can be taken with partners in the here and now while we're waiting for the settlement. In addition, at today's London Health Board, we had an excellent session on air quality, which again highlighted the importance of partners such as the NHS and local government in not only accelerating their plans on tackling air pollution and doing what they can in place, but also working together as partnership and as networks to think about the health impacts of air quality. So I think there are a number of things that we can do while we're waiting for the TfL settlement. And I think, again, the health inequalities strategy, its ambition, the KPIs that we've identified, and the core actions allow us to keep momentum on this while we're waiting.
And next question is probably more for Jazz. So what progress does the Mayor hope to achieve by the end of the implementation plan's life cycle in 2024, so it's possible to assess whether London is actually on track to meet the 2030 zero carbon and zero pollution target?
Thank you. So I think there are a a range of objectives here, and I think there are things that he will be responsible for his own actions and the way he's going to be pulling some of his resources together, but nothing is going to be done without the partnerships and the work with, for example, local authorities, with schools, with the places where people live, and also thinking about this on a global scale. Air quality isn't something that contains in one place, and I think the Mayor's role as chair of C40 is an important one here, and I think being able to really learn and keep agile. And I think the point that was made earlier about the health inequality strategy, it's not a static thing, and so actually being able to move things on. So whilst he has the agenda here, this is something that we need to get to a point by 2030, but the job won't be done in terms of having really good air quality even then. So I think it's just to talk about then in terms of the actual targets themselves. So I think using those metrics that Kevin set out earlier, understanding where we are against those on a regular basis and knowing where action needs to be taken. I think those metrics allow us, as Kevin said, the opportunity to really target where some of that action needs to be focused. And I think, for example, recognising in a local authority area where we know air quality to be particularly poor because the data tells us, and the data can tell us quite quickly, really, and action can be taken. So the Mayor's role here won't just be about doing the big population level, London-wide agendas such as ULEZ. It will also need to be about how he's able to provide leadership and support to those areas and enabling the sharing of good practice and information around how we take some of those actions forward. So I think I think what good will look like in the future will be both a combination of have we managed to hit those targets and how close are we to them, and also how more capable is the system in doing what it needs to do, and I mean at local level all the way through to a national level. How more capable is the system in being able to manage and improve air quality in its own way? So I think there's delivering the targets piece, and I think there's a piece around enabling and in his role as a system leader to ensure that he's able to encourage and move partners along with us.
Are you also tracking sort of the financial benefits to the NHS in this as well? I recall when the ULEZ rollout was announced, a figure of saying something like £5 billion over the next 30 years will be saved to the NHS as a result of that specific policy, including, sadly, we focus on the money, but actually, if you look at the figures in terms of human lives impacted, that would have led to, that will lead to on track to 1 million less hospital admissions, for example, which is a real impact, a demonstrable impact on people's lives. So are you tracking also the impact on the health service and on individuals and Londoners from sort of a wider health system perspective as well?
Yeah. So I'll begin and I'll hand over to Kevin as well, obviously. So we are tracking, and I think what it is we're tracking is really thinking about the ways in which we are reducing the exposure gap between the most and the least deprived areas in London. So at the moment, we know that we've been able to reduce the exposure gap between the most and least deprived areas in London by 71% by 2030. That's the target. And we know already that in the inner London area, we're closing that gap and moving towards that target. There will be other areas around London, so the outer London areas in particular, where we know we're further away from that target, so we've not made as much progress. So I think some of those, we'll be using that data to track the progress towards the delivery of the target.
And is there any work underway to sort of future-proof meeting that 2030 target? Just mindful that obviously, this is sort of tied up in with politicians and elections as well. And in the future, you may get a mayoral, a mayor who might decide to, for example, scrap ULEZ or delay. Certainly at last elections, we had some of the candidates saying they would delay the implementation of extending it as well. So is there anything that you're doing to sort of make that case to show the importance of how these measures are in improving the air quality in London and Londoners' lives?
Some of the best ways of future-proofing public health interventions is ensuring that you deliver on your commitments, and you can show the positive impacts and positive progress with your interventions. And the second is, of course, having robust evaluation, which looks at both the effectiveness and cost effectiveness and impact of your intervention to build that confidence in politicians in supporting the sort of future investment into the program. So for both of those, I think that's exactly what we will be doing. You know, while we're waiting for, as I mentioned earlier, the TfL settlement, there are a range of activities going on in place across the city to continue that forward motion. One of the benefits of the air quality work that we do in London is that we have fantastic academic partners that are able to help us to both evaluate both the impact of the interventions and, of course, to do the economic analyses as well. So as we move forward in the years ahead, we will continue to build those relationships with academic partners as well. So hard to get things in concrete, but certainly what we will commit to doing is ensuring that the evidence is there and that we have a positive track record of forward motion in these areas.
And how much funding has been allocated to achieve this commitment?
So we
have funding. I mean, within the health and wellbeing team, or across the GLA's work, or globally across London.
As part of this inequality strategy on the healthy places.
So we have, I can start on that. So I'm really delighted to report that through our London Health and Care Partnership, we have identified £150,000 to establish a dedicated team that will focus on air quality and health. We also have additional resources coming in from the Green New Deal of about 54 million, as well as building improvement programs of £221 million of government schemes, and a further £90 million in green bonds that will unlock another £500 million to this agenda. So you see that there's substantial investments which we're anticipating over or in progress of unlocking. And again, this comes back to a recurring theme here that, you know, there's not going to be any one agency that is going to be able to drive the progress that we need to see on some of these complex issues. And that's why I think the funding from multiple sources involving multiple partners is exactly the way to go in helping to address this issue.
Are you done? Yes. Okay, that's great. Now, I would just like to welcome our third guest, Dr. Tom Coffey, OBE, who is the Mayoral Health Advisor, who has just joined us. Welcome to the meeting. Before we move on to our next section of questions, I know that Assembly Member Boff, who is joining the meeting remotely, wanted to come in with a follow-up from that previous section. So, Assembly Member Boff.
Thank you. We know that the ULEZ, with all its good intentions, is going to reduce the ability of many disabled people to get around London. What effects how are we monitoring the effects on the mental health and health of disabled people who have had their mobility reduced?
So we'll take that away to provide you with a more detailed response, but I'd like to just reassure you that evaluation of the ULEZ expansion has been part and parcel of the program, and the impacts of the ULEZ expansion were evaluated, for example, at 1 month, and a further is planned for 6 and 12 months following operation. So the commitment to evaluating the impacts are built into the program. And I will specifically take back your question, Assembly Member, on those wider impacts on mental health and disability to the team as well.
Can you undertake to talk to disabled organisations in informing your response?
I'm happy to discuss that with the team. Yeah, I'm getting nods here, so yes, we'd be happy to do that. Thank you.
My second question, Chair, if that's okay with you, is that, of course, pretty soon we're going to be expecting many thousands more vehicles being sucked into a part of London that already has poor air quality, and I'm referring to the approaches to the new Silvertown tunnel. what particular measures are being taken to measure the impacts of air quality, both from the construction traffic, which is never known to be clean, and also the ongoing increase, the many thousands of extra vehicles that will be sucked into this part of London?
Again, thanks, Assembly Member. This is a project that I've taken an active interest in and had been briefed recently on it. And I think for all major infrastructure projects, both within the city and elsewhere, we'll always have key concerns about its environmental impact and impact on health, well-being, and other core outcomes. I think for the Silvertown Tunnel, my understanding is that there will be and there are plans in place to evaluate the impacts, both the intended and unintended impacts of the project as it progresses. And this includes looking at factors such as traffic congestion, burden, both during the construction process and, of course, afterwards. And the project itself has been designed to ensure that should some of the intended benefits not be accrued, that there are mechanisms in place to reevaluate what more can be done to ensure that those are delivered. But I think this raises a broader issue of major infrastructure projects and managing the costs and benefits. Clearly, there are going to be opportunities for improving health and air quality by virtue of improving access to sustainable public transportation, reduction in congestion, but also in concert with the other interventions which are taking place across the city, the movement towards more green public transportation, the ULEZ, etc., to ensure that the Silvertown Tunnel delivers on its ambitions. So in summary, evaluation points are being built into the project. We'll be able to look at both the intended and unintended consequences, and this is something that I think is going to be under close scrutiny as well.
I think it's a fair point that we all want better air quality, but it shouldn't be that, as far as I'm concerned, at the expense of people in one particular part of London. Can you let me know whether or not you've been involved in any decisions about the construction traffic, and whether or not that construction traffic will be using low emission fuel? There are remedies. There are fuels that mitigate emissions, and I wondered if the health team had relayed that to the project for the Silvertown Tunnel.
Well, I can confirm that I haven't been involved in providing any advice on the planning of the Silvertown Tunnel, but I will also take away to the health team your specific request as well.
So you personally haven't been. Has the health team at all been involved in the planning and implementation of the Silvertown Tunnel?
I would like to get back to you on that with to confirm our answer on that one.
I'm surprised that you don't know, but yes, I would appreciate that. And bearing in mind you don't know, I would rather hope that you could forward on to me what communication has taken place from the health team to the project for the Silvertown Tunnel, and I'd appreciate that. Thank you.
Thanks, Assembly Member.
Okay, so if that could come through the committee, that would be great. Assembly Member Sahota.
I'm not talking specifically about the Silvertown, but generally, when there's big developments taking place in London, I was involved in my constituency called the Southwold Gasworks sites, which is a contaminated site that was being developed, and air quality issues were raised with me by the residents. When I tried to approach this, no one wanted to touch it with a barge pole. Environment agents saying it wasn't our job to monitor air quality. Public health was saying it wasn't our job, right? And so let's look at the case of Silvertown Tunnel. Whose responsibility will it be to monitor air qualities, and whose job will it be to comment on any violations that take place? Who will be taking responsibility for it?
That sounds like a slightly rhetorical question.
It's a question which I want information on, because no one wanted to when I approached this question, Chair, last time, I didn't know who was responsible, and I think this is very important in any big project. We know who's going to do the work.
I think if our guests have a response to that, then that's great, and if not, if we can add it to the written response that we get afterwards. Kevin, it looks like your mic is ready to go.
No, Chair, I was going to thank you for that intervention and to say I think that would be the best thing for this specific question. I'm mindful that the health team has a particular domain of expertise and responsibility, and I wouldn't want to stray further from that in this committee at this time. So I'd like to take this out.
Thank
Come
you.
back to the committee on this.
I think it is something where, you know, these big infrastructure projects, as Assembly Member Boff and Assembly Member Sahota have raised, they do have impacts on communities, they have impacts on health, and also, yes, I mean, huge numbers of people locally in Newham have contacted me about the dust from the construction traffic from the Silvertown Tunnel. And, you know, these are things which in central London, lorries get hosed down and washed before they go out on the public highway. And that doesn't seem to be happening out there in East London. And so it may be that there are some things that the health team can intervene with Transport for London and suggest that there's a bit of improvement in terms of the way that the construction process is being managed, on top of the questions about the air pollution. I'm going to move us on to our next section, which is on healthy living, and this is looking at active travel, something very dear to my heart, and where Transport for London in the and the Mayor in the Mayor's transport strategy have actually done a huge amount of work over the last 5 years on taking a public health approach to healthy streets and to walking and cycling, it seems to me to be a very good example of where a public health approach is to policy has been rippled through a policy document of the Mayor. And, you know, I'd really like to commend the transport strategy as a really good example of that. So my first question is, how will the impact of increased active travel on health inequalities be measured and evidenced? And what progress does the Mayor hope to achieve against this commitment by the end of the implementation plan's life cycle, given that we've got the commitment of 2041 having, I think it's 80% of journeys to be made by active travel?
So thank you, Chair. So like yourself, this is an area which I'm particularly passionate about, and I've spoken eloquently and repeatedly about the importance of physical activity, both for improving physical and mental health and well-being. The core indicators that we will be tracking will be ensuring that all Londoners are active 20 minutes per day, of active travel 20 minutes each day in order to stay healthy, and the target date for that is 2041. We know that the impact of the pandemic in the last 2 years has had a negative impact on the proportion of Londoners who are able to meet this target. In fact, we've seen a relative stabilization in this target over the past couple of years, in part because of the impacts of the various lockdowns, but also in part because of changing patterns of work and the nature of active travel in the city as a result of the pandemic. Now, with the reopening and the lifting of restrictions and the return to work, we would expect to see some movement in this. But I agree with you, Chair, that the degree of progress that we would need to see to achieve the target by 2041 would mean that we'd need to see a significant step up in the annual change in the proportion of Londoners who are being physically active in this way. So this, therefore, really highlights the importance of three key things. First, the importance of us really developing the active travel plan. We've earlier reflected on TfL's plan which is being developed, and we're waiting for the settlement for TfL to look at this overall strategy for this. Second, for us to be working very closely with our partners in local government or directors of public health who are committed to increasing physical activity and active travel. And that certainly is a key part of the work that we do in OHID with JLA colleagues and our Director of Public Health colleagues in local government. And thirdly, ensuring that we continue to mobilize all of our communities, especially engaging some of the communities which we know are less likely to be practicing active travel. For example, our Black, Asian and minority ethnic communities, we see lower levels of active travel in older age groups. So ensuring that we're mobilizing, incentivizing and nudging through behavioral insights and communication messaging around active travel. So I think this is an area where we will need a whole system approach. And as you said earlier, it does lend itself very much to a public health approach to increasing active travel.
Yes, I think it's getting active physical activity into those daily journeys, walking to the shops, getting off the bus one stop earlier than you might otherwise, kind of just building activity into everyday life rather than sending people to the gym. And I think a lot of public health messaging historically has been about getting people to sign up for an exercise class rather than thinking about how to get people building that activity into those daily journeys, just how you're getting from A to B. Do I see, Tom, have you turned your mic on because you want to come in at this
would you
point?
mind? First
Not
of all,
at all.
To apologise for being late. I had a meeting I couldn't get out of, so apologise, but thank you for allowing us to attend. I just wanted to build on the point you said anecdotally and just give you something we're doing as well. So as a GP, if I've got a patient in front of me, I no longer say go to the gym. I just say, tell me where you go every day. And usually they either get a bus or a train or a car. And I say, okay, let's work out, can you get off one tube stop early? Can you get off 4 bus stops early? And just walk that last bit there and walk the last bit back. And that usually is enough to do the 20 minutes of active travel per day. And I'm sure you'll have heard my colleagues previously talk about health and all policies. And I remember when the transport and travel strategy came out, I said, this is not about buses and tubes, it's about walking and cycling. And it's a health improvement approach. And what you'll see, many other things we do about making sure people have access to green spaces. You're more likely to be active if you're near a green space and can walk to that green space. Also, the school super zones, building the daily mile into schools. It's no silver bullet. There's no one magic wand to give everyone membership of a gym. It's changing their lives and adapting their infrastructure to allow that 20 minutes of active travel to be easy, convenient, hassle-free, feel healthy. So, I'd like to say that, echoing your point, it's about changing your life and changing the environment.
And do you feel that you've got health partners on board with the idea of getting more people walking and cycling and building that activity into their daily lives? Because I think, I've been campaigning on this stuff for over 20 years, and I think, in the past it's actually been quite frustrating because it's felt like some of the sort of medical or doctors' messaging has not actually been up and along with the ideas around active travel. And I'm just wondering, do you feel that you're really cutting through and that you've got the support of kind of medical teams, in all parts of healthcare across London with this?
I'm happy to reflect on this. It certainly has been a journey. So prior to doing this role as regional director, I was National Director of Health and Wellbeing. And so one of my roles was to develop a national strategy for physical activity, which was built upon the principle of everybody active every day, and looking at how we activated professionals and got professionals to encourage people they're in contact with to promote physical activity, promote active communities, active travel, for example. In the health and care system, we've made great progress with social prescribing for physical activity. So working with social prescribers, primary care practitioners around the importance of physical activity. We've also invested in primary care physical activity champions, which have done a great job in working with their peers to promote the benefits of physical activity and to link practitioners to community assets to promote physical activity. National government has launched a number of campaigns on physical activity, which we amplify regionally and locally, working in partnership with local authorities. So that message around the importance of physical activity is both reinforced and supported as well. And again, as we emerge from the pandemic, do remember that as part of the London Health and Care Vision, promoting physical activity and active travel are going to be key parts of our commitments as a health and care system. So I would say that, yes, the focus has been on COVID over the past couple of years, but I'm keen to ensure that we sort of get back on target with our promotion of physical activity and active travel.
And just to add to that, so every single NHS trust in London now, I think by the end of March, has to publish its green plan. And part of that, for most hospitals, you want to say, how do I cycle safely to my hospital? How do I walk safely to my hospital? You know, and it will be, you know, kind of saying, you know, do we need to really provide, you know, enormous car parks? We really want to make it safe for people who can walk and can cycle to the hospital. And I think that in the NHS, you know, when perhaps 5 years ago weren't as on board, I think now there really is a movement about air quality. It's very linked to this as well, and active travel. It isn't just about obesity, it's about arthritis, diabetes, heart disease. The benefits are phenomenal.
Yep, the number of health conditions that can be improved by a bit of regular daily physical activity is incredibly broad. Now, you've mentioned several partners who are working together on all of this. How has any funding been sort of that kind of mobilization type funding that we were talking about earlier? Has any funding been allocated to sort of help coordinate all of this and make it, you know, pull all the threads together and make it happen?
So as we mentioned earlier, the budget will be agreed following the final TfL settlement from government. But I would hasten to say that the funding for physical activity not only rests within the GLA, but certainly rests in the public health grant, in local authorities. As you've mentioned, work with the NHS and the NHS's commitment to active travel and a sort of greener New Deal within the NHS moving forward. So this is an area where we have funds and pots of monies for physical activity in many places. And once we have the TfL settlement, I think that really gives us a chance to see how we provide that value add and additional impact to amazing work that's being done across the city in this area.
Thank you. I'm going to move us on to the next section, which is healthy communities, and I'm going to bring in Dr. Sahota.
Thank you, Chair. Professor Fenton, can you provide an update on the London Recovery Board's structural inequalities work, please?
Yes, I'm really pleased that we had the Recovery Board meeting yesterday, and the final deliberations and report from the structural inequalities subgroup was presented at the board at that time. What's exciting about the paper is that it really focused on 4 key areas for action across the city and across our partners, and these included action on the labour market inequality, tackling financial hardship and living standards, tackling equity in public service, and a focus on civil society strengthening. And a key element within all of these are a number of core actions that were articulated by the subgroup, which were ratified by the London Recovery Board yesterday, which focused on tangible actions under each of these 4 themes. Key among those were ensuring that we were able to look at how London creates the governance and the partnerships which are required for action in all of these areas, as well as key commitments from this group that then could be informed by and to be tracked in the Health Inequalities strategy. One of the things I'm particularly pleased about by the work of the group is its work on tackling structural racism and the importance of really working to think through what London partners should be doing in this area, especially because this has been a key request from our communities arising from the COVID-19 pandemic. So I'll pause there, Assembly Member, in terms of the initial report from that subgroup.
When do you think you'll be publishing this report? And when will the commitments be finalized and the public domain?
So I believe the Recovery Board papers are publicly available, but I'm pleased to report that there will be a major launch of the report in later on in the spring. And that will enable a range of London partners and communities to be engaged in both celebrating the progress that has been made, but also reinforcing commitments on implementation.
So I take it that means before the 30th of June?
Yes, definitely before the 30th of June. Yeah.
Okay, thank you. The other thing is that funding for the implementation plan has already been allocated before the key commitments have been defined. What funding, if any, has been earmarked to help take those commitments forward?
I think I'll need to get back to you on that question specifically. I don't have a funding figure here in front of me at this time.
That's right. If you can write to the chair, that'll be fine. That's fine.
Great.
And you spoke just a little earlier on about the structural inequalities and the importance of them. When you look at the government's paper on levelling up, right, do you think there's too much focus there on geographical inequalities and neglect the inequalities based upon race, disability, gender, and sexual orientation, or have I got a wrong reading of it?
You know, from my reading of the Levelling Up White Paper, I think that the focus has primarily been on some of the geographic disparities. But I think the door has clearly been open to understanding the impact of other inequalities and how partners at every level should be working to address those. I know that there are other government white papers which are planned, which will have deeper reflections on disparities, for example, and other inequalities, and that may well provide us with an opportunity to tackle some of those other issues which you've mentioned. Key among all of this, though, is using all of the opportunities which are coming up with new government white papers to see how they align with the work we're doing in London and how we may take full advantage of any new funding opportunities or policy opportunities which may present themselves. So the health team, working with partners in the NHS, OHID and UXA, will be actively tracking those opportunities for us as well.
Good. Thank you. Thank you, Chair.
Thank you to you. So we're now moving on to the next section, which is the second Healthy Places section, where we're looking at the living wage commitment, which is a commitment to the Mayor will lead the campaign to make London a living wage city, targeting accreditation of an additional 1,600 employers, lifting at least 48,000 people onto the real living wage and putting £635 million in Londoners' pay. And this is a new key commitment. So my question to Jazz and Tom, I don't know which one of you wants to lead on this. How does the London Living Wage commitment help to deliver the health inequality strategy and reduce health inequalities in London? And how will the impact on health inequalities achieved by this commitment be measured and evidenced?
Thank you for the question. The impact of inequalities is probably quite stark. The level of poverty, that is in London is significant, whereby 74% of adults in poverty are working. So if we can raise their working wage, we can reduce that poverty. Another indicator which I find useful for every £1,000 extra per year you pay someone, that gives them an extra 0.5 years of healthy life. Thirdly, when we ask people to assess their health and well-being, if you're poor, 34% of people say their ill health is significant. If you're in the highest bracket, it's only 11%. Those three facts show that addressing poverty inequality will affect health inequality. Now, the second question was?
And the second question was, how will the impact on health inequalities achieved by this commitment be measured and evidenced?
So there is a national survey which looks at people rating their health. That is one which I just quoted from for the highest and lowest bracket. So that one will be monitored regularly to see, are we getting more people describing themselves as a good health? Secondly, we're going to be looking at people who are in work and are classified as living in poverty. That's gone up in the last few years from 62% to 74%. We'll be monitoring that to see, can that go down?
Thank you very much. And then the actual campaign that the Mayor is going to lead to make London a living wage city, what's that campaign going to look like? What will be the key elements of it? And how is it going to be structured so that employers are keen to sign up?
So the campaign is very much a partnership, and Sadiq will be one of the co-chairs of the London Living Wage City Work Steering Group. And so the structure there will be involving health and care setting, micro businesses, the nighttime economy, the voluntary sector. So that will be very much a partnership group, who cover the majority of the employers in London. We'll be doing it using the Living Wage Foundation and Citizens UK, because they're leading this campaign. They're the one who are forming the targets, who will be monitoring the targets. They're funded by Trust for London at 4.8 million. So they'll be funding the campaign, which will be a partnership campaign publicly to work with employers to move them onto the living wage. We also have something called a good work standard. So that'll be another avenue that we'll be using to ask employers to be signing up to the good work standard. Again, I will be saying this till you're sick in the teeth, health in all policies. So we've got a Deputy Mayor for business, and he'll be a key partner in working with the business community and his contacts to ensure we move people on to the London living wage. One thing which I was kind of quite pleased to see as well, research by both Cardiff University and Queen Mary's University looked at the impact of the London living wage proposals on recruitment and retention. And this is at a time when most industries have a big workforce crisis. And they found that if you pay people more and take them up and above the London living wage, you will increase your retention and you will increase your recruitment. And that will be the message we'll be taking via the Deputy Mayor for Business to our London businesses. And not only will you have a healthy workplace, you're more likely to retain your staff, which at the moment we're very much aware of. Workforce crisis can really undermine how our business in London works.
Thank you. And so this is another area where basically it's about the Mayor partnering with other bodies outside of the GLA to help to deliver these sort of good outcomes for Londoners.
And an approach I always say that when people say, well, what does the Mayor do? And I say, well, the Mayor can do and commission things, but also often as powerful in his soft powers of convening, advocating and shining a spotlight. And I think he'll be doing all three in this area, convening that steering group, shining a spotlight on it, and advocating on behalf of Londoners to employers to raise everyone onto the London living wage.
So the commitment aims to lift 48,000 people onto the real living wage. So how many of these are estimated to be Londoners, given that presumably some of the employees of the 1,600 employers that are being targeted will be commuting from outside of London?
I don't have the exact figure, but it's definitely, what you say is a reality because, many Londoners, work outside London, and many people from Surrey and the Shire counties work in London. So that will be being monitored by the Living Wage Foundation and Citizen UK. So I can get you those figures, but to be honest, only as we do it, will we know, what those figures are. But the majority, I would reckon, will be in London and Londoners. And just one area that I was quite surprised about recently, whereby the NHS now is really moving on board with this. And I often talk about challenge and champion the NHS. But since the COVID pandemic, I think we in the City Hall have learned to collaborate with the NHS as well. So we've now got 8 NHS trusts signed up to become London Living Wage employers. And last week I met with the LAS Chair and Chief Exec, who said they're bringing all their cleaning staff back in from an outside provider and they're moving them all onto London Living Wage. So the NHS are real living partners to this process.
That's very good to hear. The commitment talks about an additional 1,600 employers. So are you expecting these to be 1,600 new employers, or is this a sort of is this 1,600 new employers, or are you expecting to make the total number of employers?
No, it's 1,600 new additional employers signing up to London Living Wage.
Great, thank you very much. And what was the process that was used to identify and agree this commitment? I mean, presumably there were discussions with the various partners. So who was involved and how were those decisions reached?
So it was very much a collective process. And I can remember a few years ago when we were just launching the Child Obesity Task Force Action Plan. And one of their key commitments was London should address poverty because poverty causes childhood obesity. And then I said, okay, then we'll try to, that's a key thing area. And then we looked at all other causes of poor health, poor mental health. Again, it was poverty and income inequality. And then we received some reports nationally from Sir Professor Michael Marmot on his Marmot report, again clearly saying that health inequalities is intrinsically linked to income inequality and poverty. And then when we look at some of the work that's been done by David Buck from King's College, just focusing on using a city as a body to improve the health of those Londoners. It's not about necessarily just the borough or about the health service, it's about the powers of the city, be it Andy Street or Andy Burnham or our own Mayor Sadiq Khan. So we got all that information from our advisors, from external research, and then very much the Health Equity Group, which Kevin chairs, has those wider partners of the local authority, the NHS, the voluntary sector, citizens, and they together decided, the links between income inequality and health inequality is so stark that this is something that has to be on a health agenda. And I don't make any apology for the fact that this isn't about diabetes or heart disease, because this is what will make a difference.
Thank you very much. Now, my final question is a sort of practical one, which is just how much funding has been allocated by the Mayor to deliver his campaign in terms of the campaign that he's going to lead to make London a living wage city?
So the funding is multi-layered. So therefore, he will be using the resource of the people he employs to support the campaign and the Secretariat, because the majority of the funding, the 4.8 million, is coming from Trust for London. Secondly, as a procurer and as an employer, we will make sure that our procurement contracts have built into it that people who wish to succeed in these contracts will have to be paying the London living wage. That comes at a cost. And then over the time, when we may see some of those costs of the procurement increase, but that is the cost that the GLA and the Mayor wishes to bear to take those Londoners out of poverty. But there isn't a set fund which we've set aside, but the added on costs of the human resources support is there. We do have the Good Work Standard, which has its own funding stream, which will assist the process, because you can't sign up to the Good Work Standard unless you're a living wage employer. So again, that's another cost. If you want, I can get them all and add them all up and get back to you. But there isn't like 4 project workers. This is convene, advocate, spotlight, and do. So all those come with costs, but well worth spending.
Well, I mean, if there are some numbers that could be shared with us, I think that would be really helpful. I mean, I think we do understand that what you're doing here is kind of bringing people together to deliver better, to reduce health disparities in our city, but we do also have a job which is to scrutinise what's going on, and it's kind of because of the way this is structured and set up, which is clearly creative, it's getting good partnerships going, and that's always good, but it also makes it very complicated for us to be able to see what's actually happening and what's being delivered with what and everything. Anyway, that's it from me. I am now going to bring in Assembly Member Best, who I think has a follow-up on one of my earlier questions in this section, and then will take us into the following section, which is healthy children. So, Assembly Member Best.
Just go straight in after. Perfect. Thank you, guys, and afternoon, Tom. Just following up on Assembly Member Russell's previous question on who was involved in the decision making, was the Deputy Mayor for Business involved in this commitment?
Yes.
Perfect, thank you. The other question I had was the Economy Committee previously called on the Mayor to implement an action plan to boost the uptake of his Good Work Standard. Is that something that our health representatives here would also endorse happening?
Yeah, and so we are very much involved in that as well. So you would have remembered we had what's called a Healthy Workplace Award. And so what's happened over the last few years, we've transformed that and integrated it into the Good Work Standard. So we were giving out awards, throughout London to make sure that we had a healthy workplace. This is about good mental health, good physical health, and good work policies. And so we believe rather than having a Good Work Standard and a Healthy Workplace Award, we thought we'd put them together. So we've been very involved in it. And if anything, all the aspects of the Healthy Workplace Award have been integrated into the Good Work Standard. So we've been very involved.
So would you endorse the Mayor delivering an action plan to boost the numbers of those that are signed up to the Good Work Standard?
Yeah, I mean, I would endorse anything which improves an uptake of a Good Work Standard.
Perfect. Kevin or Jazz, I don't know if you think there should be an action plan to try and boost uptake, or just... I can move on.
So in terms of, there kind of is an action plan in the sense that there is it's a running programme. It's
not on the programme, on an action plan to boost the numbers, because the uptake has been less than great in certain areas. So an action plan to boost the numbers standing up to the Good Work Standard, and as a result, of course, sign up to the London living wage.
Yeah, so a specific dedicated programme for the Good Work Standard set apart from the wider work, I wouldn't recommend. I would suggest that the core work here, that should be done through the partnership and the steering group that the Mayor is co-chairing but working with partners on, is where we would want to see the Good Work Standard contributing to. So rather than a dedicated separate work strand, the wider work strand is the one where I think the Good Work Standard would be best placed to kind of contribute to.
I'm not quite sure that answers the question, but that's fine. The other question I had around the London living wage, and obviously Tommy spoke earlier about the massive impact a good wage has on health and life expectancy. And my colleague Andrew Boff talked earlier about evaluating the impact of the expanded ULEZ on disabled Londoners. Could you also undertake to look at the expansion on small businesses?
So of the ULEZ?
Of the expanded ULEZ.
It would be wrong of me to give an undertaking that I haven't got the power to do, but I can advocate on your behalf if that's what you'd like me to do, and I'm happy to do that. But I can't give an undertaking something which is not in my gift, which would be unfair. So I'm sorry.
Thanks. So I think what we need is to understand the impact on disabled Londoners, small businesses, for the reasons that we're looking at today. And so to make sure in further evaluations of the success of the ULEZ, we look at how we ensuring those people aren't left behind.
Yeah, and I think it's a fair point, and I think I would take the message you've given me and pass it on, because I think, you know, what I don't want to do is undertake something I don't have the power to do so, but I can definitely communicate a concern that you've got, as we all would have, about the well-being of disabled Londoners and how they live their lives. You know, and as I would probably say, is disabled Londoners also need to breathe good quality air, and and that's what it's important that does happen. But I will take that message back to the team, and make sure that is clearly made.
Thanks.
I'm not sure what's been asked of. Are we asking the health team to look at impact on businesses of ULEZ?
So
is that are we asking the health team to do that?
We're talking here about the London living wage, as you'll see from the section.
You mentioned
Sorry,
ULEZ.
can I finish speaking? Thank you. So we're talking here about the London living wage. Of course, you'll understand that paying the ULEZ charge affects small businesses in the same way that a London living wage does. So if we are to put economy into health and health in all policies, we therefore need to evaluate the effect that the ULEZ has had on small businesses as well as on disabled Londoners. And as those are two things that we've talked about today, it would be good for the health team to advocate, as health in all policies, how we don't leave behind those on low incomes as well as disabled Londoners. Because as Tom rightly articulated, it is intrinsically linked to poverty and poor health outcomes. And so that is what we're doing today, is we are making sure that we evaluate everything in a health in all policies approach. And that's what you'll see in your paper before you.
Sorry, Chair, I was just clarifying, because it felt like what was said was they were being asked to look at the impact of ULEZ on businesses.
I think there is, if we're talking about health disparities, we do need to evaluate the impact of all policies on all disparities, and so and actually I think it's an interesting line of questioning, and if the Mayor is putting health in all policies, then we do have to think about the impacts of all policies on, as Assemblymember Best said, disabled people, and also on businesses, and in particular on those small businesses, their ability to pay the living wage, because that all impacts on Londoners' health. But I don't know, was one of you about to come in on this?
Thank you, Chair. I believe the action is for the health team to advocate on these issues with colleagues who are responsible for the evaluation, so that the evaluation takes into consideration some of these wider indicators or wider issues as well, which we would be happy to do with colleagues who are charged with the evaluation of the ULEZ. Yeah.
Thank you, and thank you. Yes, I'm just going to move now on to healthy children.
Thank you.
Still on this last section. Of course, the quality of air in London is of importance to everyone, regardless of whether you're disabled or you're a small business person or not. No one can risk air quality being detrimental to anyone's health. Okay, and that's an overriding factor. But just come specifically to the question about work standards. Do you think that the low pay is a particular issue amongst young Londoners? And do you agree the government should help tackle the health inequalities by allowing all over 18s to access the highest level of national living wage?
The number of people in London, who are earning before the London living wage is definitely higher in young people, and we know there is a cost of living crisis at the moment regarding rents, regarding fuel bills. So it would seem sensible to make sure all adults get access to a wage which moves them out of poverty. I think what this government and previous governments have done when they've looked at minimum wage and they've adjusted it for age, because often the younger adults are often in training and education, they're often living with their parents, to mitigate the impact on the economy of an increase in their income. However, I would definitely be supportive of maximising the number of people who work and get the London living wage.
And also another impact, Dr. Coffey, is the fact that the statutory sick pay doesn't match the London living wage. Do you think there's a case for raising the statutory sick pay so
Yes.
people? Well, that's a very clear answer. Thank you very much. And just one more thing, to come back to you, Jez. This is the program to increase the uptake of the Good Work Standard program. I know that the big employers are adopting it and it's easy for them. But how are we targeting the SMEs to adopt the Good Work Standard? Are we focusing on that sector?
Yeah, so there is a new work stream because I think you're right, is that the very large employers often find it much easier to have an HR department, to have a training department, to have an occupational health department, employment assistance teams. It's much more difficult if you're a small business. So in fact, on the London Living Wage Committee steering group, there is a particular work stream on what they call micro businesses, small businesses which need the extra support, to move to the Good Work Standard and the London Living Wage. And I would say very clearly that all businesses are finding it hard to recruit and retain, and therefore I would hope that as everyone around you becomes a London Living Wage employer, that raises everyone's standard. But I do recognise the need for the smaller businesses to get extra dedicated support, and that is happening.
Yeah, thank you.
Thank you. We are going to have to keep up the pace, everyone. Assembly Member Boff wanted to come in on this point. If you could be as succinct as possible, that would be super helpful. And then back to Assembly Member Best.
I shall try my best. Mr. Coffey, do you think it's important that any measures that the Mayor adopts in order to improve air quality and resolve poverty should not disproportionately fall on those people who are least able to pay?
Yeah, so therefore a consistent theme that Sadiq will say, is it's not just health in all policies, it's health inequalities in all policy. So, and I'm going to equate your kind of people having more difficulty to pay, i.e. it shouldn't unfairly fall on those who have lower income. Yes, that's what I agree.
So, for example, when people are unable, for example, to change their vehicle due to not having the funds and there being an inadequate scrappage scheme, those costs of the ULEZ policy surely do fall disproportionately on those people.
Yeah, so I think when I've looked at a policy in the round, that the people who drive cars in London are the people who are on the higher incomes. The people who live in the poorest air quality are on the lowest incomes.
I'm not talking in the round. I'm talking specifically for those people who are unable to pay the costs of everybody else's clean air.
Yeah. So what I suppose what I'm trying to work out is that when one makes a policy, you have to balance the impact on everybody. And I would definitely be supporting, if the government could fund a more generous scrappage system to help this make this
That's
happen.
down to the mayor, isn't it?
Right.
The mayor can fund his own scrappage system.
I think if the government's TfL settlement is very generous, that is something I think we definitely would want to consider. But at the moment, those negotiations are very tight, and I think at the moment what we're trying to do is do policies which maximise the benefit for the most people. And I think the air quality policy in London will have that maximum benefit. But I am very sympathetic, to those Londoners who, will find it very difficult to, do those car changes. But overall, the impact on their health is so significant. London has 6.4% of premature deaths in London are due to poor air quality. That is the highest percentage in the country. We need to act now.
So your utilitarian argument there basically does argue the fact that if some people suffer, it doesn't matter as long as the rest are okay.
No, I think that I'm just trying to make a policy and support a policy that has maximum benefit for Londoners.
Even poorer Londoners who can't afford your policies.
I think what you'll find is that the poorest Londoners will be the greatest beneficiaries of improving air quality. Because as I've said before, the poorest Londoners live in the area with the poorest quality air.
I'm going to call a halt to this one now and bring in Assembly Member Best. Otherwise, we're going to be in this room forever.
Thank you. And we will talk about school super zones, but I do think, Tom, when you're making that point, you are forgetting the vital difference between outer London and inner London. For example, in an area where I live, the poorest Londoners are driving because we don't have any public transport. I see if you're talking about inner London, that's a different case. So on to the school super zones. This is to Jazz and Tom, please, whoever wants to take it. How will school super zones help deliver the HIS and reduce health inequalities in London? And how will the impact of school super zones on health inequalities be measured and evidenced?
Okay, so if I start and Jazz may join. So when we develop some of our policies, we've got to make sure we target them. So for the school super zones, so they were evaluated by the University of Manchester, looking at how they create around a school areas of better air quality, safer streets, more ability to more active travel, around schools who do water-only schools, a daily mile, schools which have mental health first aid. And therefore, the benefits that were shown by the evaluation, were significant. Therefore, as we roll out now for 50 more super zones around schools in London, we'll be targeting those at the boroughs with the most deprivation. So therefore, what we want to make sure is that this is not a universal approach, I have to say, at the outset. So we're going to deliberately target our resources on the poorest Londoners. So the benefits from the health benefits from the school super zones will therefore fall on the poorest Londoners. The evaluation thereafter, so we have got evaluation funds actually built into the project. And in fact, 4 days ago, they had their first meeting to decide how they're going to partner with local authorities. Because this is one of those areas whereby, and I've said it the same, London Living Wage, this is a partnership approach. The real delivery people for this are the schools, the parent-teacher organisations, and the local authorities. And we're providing very much the seed funding and the model and almost the curriculum. So there will be an evaluation, and there's funding set aside for that to occur, but we're trying to work out whether we do it across London or do evaluations almost borough by borough and allow our borough partners to have a lead in that process.
Yeah, because I suggest, having looked at the pilots, the outcomes are very different and the proposals are very different. So having a one-size-fits-all monitoring system is probably going to be difficult to work. So it would perhaps have to be in a line by line. But given that, how easy is it going to be to monitor what is the most effective policy when it's going to be so different in every borough? So it could be the culmination of policies, it could be one separate one, but given the difference in areas and difference of combinations, how are you going to pinpoint that?
No, I think you're right. So therefore, there's two principles attached here. One is about flexibility, is that so the school super zone isn't one of those prescriptive programs to say, if you are going to follow a school super zone, you must do these 4 things in this fashion, in this way. We're not doing that. We're saying there are many parts of a school super zone, and a local authority and that school and the parents will decide what's important. So the flexibility, I think, as you're right, inherently means it's much harder to evaluate because you're not having everyone doing the same thing. And that's why we're looking at each borough doing its own evaluation and us supporting it, as well as a London-wide evaluation. Because I think what we'll probably find is, and I'll give you examples here, you may get 20 of the 50 super zones focusing on safer streets, another 25 of another 50, say, focusing on air quality, another on a healthy food environment. So we might have to match them together, but I think we're going to have what we call a matrix evaluation, because otherwise we have to remove that flexibility that we've given schools. And schools have always said to us, and local authorities, we want to work with you, but don't tell us what to do. Right? You could give us the tools to do the school super zone project, but please, and I think in our evaluation of the first, host of super zones, it was a flexibility which allowed local people to really design it, and that is a core principle of our school super zone project.
Thanks, and certainly agree with that flexibility element. The concern I have around a lot of the school super zone travelling projects is how it has helped people that are time poor, and I think there's a way to do that, but I couldn't see it in any of the pilots, and I wonder if it's something that you'd been looking at helping as an option with this funding, and that's breakfast clubs and making sure that every school involved has an early morning breakfast club, which not only allows the schools to provide a good meal for the start of the day for the children, but also allows those parents who perhaps are doing multiple drop-offs to nurseries and schools and then work to have that extra time and flexibility, which may allow them to have that active travel.
So first of all, something I should say at the beginning, I know your role obviously is to scrutinise and evaluate us, but I would really appreciate your feedback to us, because a lot of these projects are in the formative phase, and so I will actually feed that back, because when you talk about active travel, and it was something which the chair said at the outset, you've got to remove barriers, right? Because if you talk to people say, no, I don't want to be actively travelling. No, they do, but you've got to make it easy and remove barriers. And that's why the idea about making you feel it's safe, making you feel that the air quality is good. And if to be honest, trying to do the kids' breakfast, and then getting them to school, and I've got a 10-minute extra journey because I'm going to walk, you can say, but when you get to school, the breakfast is there. That removes a barrier and it promotes active travel. So if you don't mind, I'll steal the idea and bring it back to the group.
Thank
Could
you.
I
Did Jez want
add? Yeah. So I think kind of what I think is really exciting is the super zones are. I mean, how I've understood it and how the team have taught me about it, I suppose, is the super zone is the space around the school. Healthy Schools London is the programme in the school, and what's really important is how those two schemes work really hand in glove to understand exactly as you're saying the kind of the potential here for the choices families might make. Actually, am I going to be able to spend 10 minutes on walking the kids to school, or do I have that 10 minutes to feed them? And I think those sorts of questions become really much more kind of manageable when we're understanding the lives of the people that we're trying to support. So actually that's a really good example, isn't it, about how our engagement with communities, and I think the value of super zones and local authorities being in the driving seat of them, with the relationships with the schools that they would like to super zone around, I think is going to be the opportunity for how that real place-based kind of opportunity for getting the model right for that local place and that local community becomes really important. I think the other ideas that we're seeing come out beyond the evaluation, and we're seeing now in some of the conversations that we know are being had in local areas, are about how more creatively can they use the wider assets in the community as part of the super zone. So we're already hearing where, for example, primary care networks and GP surgeries are keen to be involved in some of those relationships going forward because they want to do far more outreach with those communities. So I think there's kind of, it feels to me it has the potential to be a really positive Christmas tree on which lots of things could be kind of lots of really positive baubles could be added. I think there's some mileage to go before we get there, but I think that it's kind of exciting people locally, which is really, really interesting.
I think we've covered this quite a bit, but I wonder if there was anything you wanted to add to what process was used to identify and agree school super zones as the Healthy Children Key Commitment for 21 to 24, and who was involved and how were those decisions made?
So again, I'll probably ask ask Kevin to get involved as well, because he chairs the Health Equity Group, because that was the final decision-making process. But I think what it was that I think you'll see hopefully a theme in how we're approaching our healthy children, and it's building around the school. So we've got mental health first aid in school, we've got healthy early years, we've got healthy schools, we've got a daily mile at school, we've got a water-only school. And I think what we wanted to do was just build it a bit further. It's the environment around that school, especially for primary schools. Most people who go to primary school in London live within 400 metres of that school. Yeah, and you tend to kind of, you walk or you drive there, depending. And I guess what it was it naturally fitted into the idea of using the building block of the school as a way of promoting good health. And it also had that health and all policies theme. It wasn't just about childhood obesity or just about air quality, it was all of those. And so therefore, that's where the idea came from. We tested it out, obviously, in our various kind of the big conversation networks. We do surveying, and eventually the decision-making process was via Kevin's group, the Health Equity Group, who looked at it and said, because we could have just carried on with the healthy early years, right? But that is just so successful, it would have been too easy. Because we thought we'd get 1,300 in the first 3 or 4 years, got over 2,000. And because it's pure luck, no, it's not. Because of judgment, the curriculum of the healthy early years matches the Ofsted curriculum for you to say you're a healthy place of education. Many healthy early years places just took it up. So we took the braver decision not to do something which we knew was already working, but to add to it, and hence the reason we chose super zones.
And if I could just add here, in terms of the partners that have been involved, this is another great example of us working across a range of stakeholders. So ADPH, Association of Directors of Public Health, that represent our local councils, Public Health England, and now my team in OHID, the Town and Country Planning Association, and of course, as you've mentioned, Tom, the Health Equity Group, which also has a wider range of partners sitting around the table. What's really beautiful about the school super zone, and why I think it's an important key performance indicator, is that it is a combination intervention. So what you're doing is using the school as the unit of intervention, but you're looking at a range, as you said, Tom, a range of activities that can help to improve the well-being of our children. And that's why I think it has the strong support of public health directors across the city. Thanks.
Thanks. In January, the Mayor confirmed £1.8 million of funding for the GLA to establish 50 super zones. So how will that be allocated?
So that funding is over a couple of years, and we're going to do it in phases. So in year 22, 23, there'll be the first tranche of funding, and then in year 23, 24, the second tranche. So the overall total of funding is 1.8 million. And so the funding, how it will work is that each school super zone, and we work with our local authority colleagues, will be allocated £30,000 of seed funding, which allows them to do some of the structural work. So when you create a healthy street, you're going to buy those yellow elastic things which kind of close off your streets, and you've got to maybe do things to adjust to improve the air quality around your school. And so when we did the pilot previously, the local authority just welcomed that extra funding. And it isn't all that is needed, because the local authority will have to put money in. And what I'm hoping to create is a jealousy level movement whereby my school's is a school super zone. Why isn't my school a school super zone? Whereby we get other partners funding now to match what we're doing as well. Other local authorities also seeing this as a real project which can benefit the children in their school. Because 50 school super zones in London, on top of the ones we've already had, isn't sufficient to transform all of London. But I think it's starting a process which I believe parents and teachers will want for their school and for their children.
On that jealousy point, it was one of my next questions, is just to ask, will you, of those 50 super zones, I know that they're going to be targeted via deprivation and obesity levels, but will you make sure that there's one in at least every borough? So,
Definitely.
for example, you have...
Definitely. That is one of the principles. It's about kind of targeted universalism. So every borough gets one, but some will get more, but they'll be targeted probably because it's health inequalities at the poorest areas of those boroughs.
Perfect. Thanks. And how will you work with the GLA? How will the GLA, work with local authorities to deliver the commitment?
So I'm going to bring Jazz into this one, but obviously the ADPH's network is the vital thing. So we're going to be using principally directors of public health from each school, from each area, and directors of social children's services. So therefore, we're providing this infrastructure and some of the seed funding. The delivery is the borough's responsibility.
Thank you, Tom. And I'd add, I suppose, the target of 50 super zones is the kind of key deliverable of the Healthy Place, Healthy Weight mission, which is obviously as part of the recovery programme, kind of part of the shared programme of work that we do with the LGA, and obviously the LGA and the Mayor jointly lead that work. And so local governments, both from a strategic kind of decision-making point of view, all the way through to that kind of the funding is directly to local authorities, the relationship via the ADPH, but also increasingly we know directors for children's services becoming far more interested in this programme, directors for planning and environment. So I think there's a bigger swell, I think, in local government potentially of interest than we might have even anticipated in the very beginning. And so I think that definitely feels kind of the way forward. I think the other opportunity is also to think about where there are some wider agendas across local government that could also influence some of this. So, for example, the work that we're doing that MOPAC colleagues are doing on through the VRU, looking at how safe schools and safe school environments is a real kind of drive of work that they're taking forward to support young people who are at risk of violence and crime after school, that after school time. This is an additional layer of work that supports some of that wider work. So I think it's kind of the many layers of work, I think, kind of give a much stronger potential for those, particularly those, and it's the same areas. The deprived areas we'll be thinking about for super zones are likely to be similar areas where other programmes of work are also targeting effort. So I think this is kind of all, I think, useful and very thoughtfully defined choices that have been made around how we target those areas and ensure that we're kind of double counting deliberately, I suppose, if you know what I mean. I think there's the layering of the investment and support given to those areas.
Thank you. I've got a lot more questions on school super zones, but we know we don't have time. But I do want to quickly tackle the junk food ad ban, which is something that will come into play as part of school super zones, but we know has already been in operation on the TfL network. How successful has that been at preventing childhood obesity or lowering childhood obesity in London?
So I'm just looking for the latest evaluation, which I think was only published a few weeks ago. And as we know, that childhood obesity, is a problem in London because London has the most obese children in the country, and the poorest children are the most obese in London. That's why it's kind of quite important that we do everything we can. There is no silver bullet to manage in a single way the reduction in childhood obesity. So we've got to use every single part of our armoury. We chose to use the ad ban because we'd looked at some lessons in Amsterdam and wanted to see can we replicate them in London. And therefore, when we did it, we did commit very clearly to evaluation, because I practice evidence-based medicine. I, as a policymaker, want to practice evidence-based policy. And so we committed to the London School of Hygiene and Tropical Medicine to do our evaluation, and then to see would it have an impact. And the impact we looked at was calorie intake, in Londoners over a week, because we know that has an impact on childhood obesity. Now, I would not believe that an ad ban which you do, on the beginning of a year, in a year and a half, is going to have a massive impact on childhood obesity. That's going to take years and years. What we do have to do is take what we call proxy measures of success or failure. And a proxy measure of success would be, are Londoners consuming less calories as a result of the ad ban? The evaluation said yes.
Do you think that evaluation is accurate, despite it not including any fast food, food on the go, or food in restaurants, which I would imagine are the main foods that the ad ban was targeting?
Yeah. So the importance of having, I guess, peer-reviewed research is that you're giving a degree of independence and the need for scrutiny of the evaluation you're doing. So the evaluation, first of all, was done by an independent organisation, a credible one, London School of Tropical Medicine and Hygiene, and then they put the evaluation that they conducted forward to a peer-reviewed journal. And it was the conclusion of that peer-reviewed journal that the evaluation showed this significant impact. Now, so therefore, all I can take from that is the science. And the science says to me the calorie reduction was on average for the average shopper was 1,008 calories per week. Now, did it go into, was it a hamburger, was it a different type of food? So what it looked at, in essence, was a comparison to what would have happened if there wasn't an ad ban, and that's what the peer-reviewed independent research showed.
I think we'll have to agree to disagree then, perhaps, especially on the term where the science that something excluding fast food, food on the go, and food in restaurants could accurately show what a family is consuming in a week. So the main point for asking this is that obviously with the food ban being put into the school super zones...
Chair, when someone's come back with sort of empirical facts, I think we shouldn't really try and base this comments. We're entering Donald Trump world here.
It's not empirical facts. You'll actually understand. By the way, I've got a science degree as well, and so you'll understand that research
I'd love
and
to see your
studies
peer
is
review
not
journal
fact.
into this, then.
It's not fact.
I would love to see
it's not necessarily just fact.
It's dangerous grounds to go on
anyway.
to make comments that basically rubbish.
Can we
peer
let
reviewed.
Assemblymember Best just finish her question quickly, because we are getting very short on time, and I'll then bring you in for your question that you have on the list to ask, if you can be quicker as well, please.
I will do. And God forbid you ever go into a uni and see that you actually can debate research and studies. It's not fact.
Can you just
Anyway,
ask your question, please?
I will do. With all due respect, Chair, it wasn't me that was holding up my question asking. So I wanted to ask briefly, there's not actually a clear-cut definition yet on the ads that should be banned, and we've seen this flow up in anomalies throughout the year on TfL. So how are we going to straighten that out for the school super zones to make sure there's a clear, if that was part of what's being used, that there's a clear understanding of how you don't have, for the likes of KFC and McDonald's, still advertising?
Yeah, so first of all, I would like to say is that McDonald's and KFC are able to advertise healthy food. All right? I've never said we should not have any companies not advertising. I want to see the advertising of healthy food. And one of the benefits of the advert, which I was so surprised about, because my fear was that companies that you just mentioned might pull out their advertising, but they didn't. They started advertising their healthy products. So that was a win-win situation. I'm going to bring in my colleague, Professor Fenton, in a second, because what we have done is very much use public health advice to define what is high fat, sugar and salt. And there are some quite good national guidelines, because again, I tend to defer to people who know more than me, which is quite a lot of people. So I'm going to ask Kevin just to kind of perhaps, he might say about how the public health look at this proposal, and we'll be using that kind of advice.
Thanks, and I'll be very brief, just to say that we worked very closely with Public Health England at the time with the definitions of high-fat, salt, sugar products. I was the Director of Public Health in Southwark, which is one of the pilot sites for the School Zones programme, and we also use the standards for high-fat, salt and sugar programmes to help us with restricting advertising in the borough as well. So we work with Public Health England, who set the standards, and those standards are reviewed based on the evidence that they are looking at on a regular basis. And this has been part of the childhood obesity strategy nationally as well. So we use a standard which is not just for London, but which is used nationally too.
Thanks, Chair.
Thank you. Assemblymember Harani.
Thank you, Chair. I think well, this is an issue I've also worked on in my borough for years as well, and I just want to pick on something with the school super zones and this 400-metre definition as well, because one of the problems I have with it is sometimes you get areas where you might have a bus interchange where you have pupils from a school and parents travelling to an area which is outside that 400 metres, but it might be the only place where you have maybe 6 or 7 bus routes convening in one place. And is there scope to widen that definition to look at town centres that might be just outside that 400-metre strict definition?
So in my answer to Assemblymember Best, I was very clear that flexibility. So, and I don't want to say they definitely will, because it's their decision. But imagine if you had a school which is right up against a railway line. Right? And it doesn't have every school's got a neat 400-metre circle around the school as its catchment area. A school like that might have 800 metres that way and 2 metres that way. So of course we have to really, I would say, consider the catchment area when you're looking at the school super zone, and they've got to have some sort of coherence. Otherwise, what you're saying, we would have to ignore, which would be pointless. So I would support the idea that the catchment area of the school should be taken into consideration when you're doing the school super zone distance. There might be the case that it goes too far away and it crosses local authority boundaries, or you're not able to do certain things because of structural issues. But I think that flexibility to try to make the school super zone match the catchment area of that school, especially in primary schools where the catchment area is very small, is something I would definitely support.
That's helpful. I think maybe if that's encouraged to local authorities as well, so that, because I think in their minds they will be thinking 400 metres, and that's a definition, but that could be widely encouraged to local areas as well. That'd be great. Also, I think back when I was looking at sort of policies on restrictions around, let's say, fast food outlets around schools and planning policies, one of my bugbears was that you had to go to the Secretary of State to get approval for your local plans and provisions. Is that still the case with this?
So my understanding is that the London plan has now been accepted, and the restriction of 400 metres from a school of any new kind of fast food outlet is now part of the London plan. So I'm not aware, but I will stand to be corrected, that each individual one would have to go to the Secretary of State. My understanding is now that there is the ability to restrict that accordingly. But but that is my understanding, that the London plan is now accepted. I'm looking to my left to make sure I have said that correct. Yeah.
Yes. Yeah.
And the 400 metres. I mean, again, that's one of the triggers for the school super zone 400 metre distance, because we knew, that was already in people's mind about we're going to restrict the opening of new fast food outlets in that 400 metre area. But I think the flexibility you suggest to match catchment areas is sensible.
Thank you. I think one of the issues that we always came up against locally in the borough of Brent, is where I was the public health lead, was that we did often have resistance as well. So when we submitted some of the policies through that had to go through the rigorous processes, we even had at one stage KFC's head office come and argue against some of the restrictions around fast food, especially. And we've already heard at this committee, and I think even when the TfL ad ban was proposed and came forward, all the scare stories about, at a time when TfL is under pressure, why are we stopping them from making money? But obviously, some things are more valuable than money as well. But in terms of resistance, what resistance have you faced with some of these policies around school super zones?
I have to say, very little resistance. So I think when you're working in a local area, the majority don't, have the headquarters of a fast food outlet in their base, and so if anything, often so you'll make travel changes. So when you close off a school, you do a healthy street around a school, that will restrict people's ability to travel past that school at school opening hours and school closing hours. So that does cause some concern because people have to change their journeys. But all in all, in fact, we've found minimal resistance, and I expect that the biggest drivers for the school super zones in the future won't be the teachers or the local authorities, it'll be the parents. The parents saying, I want my school to be part of the school super zone to benefit my child. So therefore, we've had very little resistance. And regarding, I'll echo that point again about the larger firms who have previously had very high fat, high salt, high sugar food, I expect them to change. Just as you now go into a food outlet and you've got vegan options, which you wouldn't have had 10 years ago. For a person who's got a child who's milk allergic, that is just fantastic. And I think we'll get the same. Those companies need to have a business model which makes money. If Londoners are choosing to take the healthy options, they will alter their menu, alter their advertising, and alter their business model. And I think we've got to be brave and use models like this to promote that.
Thank you. I think just a couple of comments on that. I agree on that final point, actually. And companies will change and are changing. And I think to the government's credit as well, some of the changes that they've made on the sugar tax have helped to alter some recipe changes in and more sugar-free options in drinks as well. So it's a combination of things that come forward to help put that point forward. So that's a very helpful, I think, putting it into context as well.
Thank you. That's it? Marvellous. Okay, we are now on to the final round of questions, which are going to be led by Assembly Member Boff, and this is looking at healthy minds and the key commitment that by 2025, London will have 250,000 wellbeing champions supporting Londoners where they live, work and play. So, Andrew, over to you.
Thank you, Chair. I'm just going to roll back a little bit before I launch onto Healthy Minds, because so much of the last discussion piqued my interest. Do we know how many young people were surveyed by Kantar?
I don't know the information, but I can get the information for you.
Thank you very much. Was there a specific reason that the survey did not include those foods which the junk food ban was specifically designed to prevent us eating?
You're going to a level of detail which I apologise for that I'm not able to answer, but I can get the information for you. Yeah,
at the moment, in terms of the junk food ban, it's a survey that doesn't talk about the junk food ban. It goes on about domestic cooking arrangements, stuff that you'd cooked at home. So it's difficult to see how that can be a justification for the junk food ban. I mean, I know I'm almost repeating the question Assembly Member Best put you earlier, but I really didn't understand the answer.
Okay, I mean, do you want me to repeat the answer or?
No, but if you want to provide me some data, that would be.
I'll do.
And just for your information, Dr. Coffey, I am a vegan, and a McPlant is just as bad for you as a Big Mac. So it's not just that.
It can be, yeah.
It definitely can, and I've eaten so many that I absolutely know that to be the case. Can we just now move on to Healthy Minds then? Could you Ms. Bogle, could you explain what a well-being champion is, how they're trained, how they're supported and managed, and what support the champions will actually provide, and an idea of how they will operate on a day-to-day basis?
Okay, thank you.
I think that was directed to Jazz.
Okay,
Yeah.
sorry. No, you fire away,
okay.
Joe. I'll chip in later.
Sorry, sure, okay. So a wellbeing champion is broadly defined, and I think kind of it's important to say that there are lots of routes in, I suppose, potentially. But effectively, they're kind of working with our partners on the who are working. So we have a steering group and a working group that supports the work of the development of this mission, and it's taking forward. They have defined the kind of concept, the definition, if you like, of who is a wellbeing champion. Is a person who helps another person, group, community or organisation to influence or inspire a simple change to support the mental health and well-being of others. So that is quite a broad definition, and I think but I think necessarily so. And there are many reasons for that. And so one of the reasons will be there'll be people that will be engaging and entering into being a champion in many different ways. So we already have a large number of people that have had specific training for various schemes, such as suicide awareness campaigns, or through mental health first aid, or through a whole range of other different means that they've had. However, the majority of these people aren't connected. They're not linked into something. They've often had the training, but they're not necessarily utilising it. And there are plenty of other people who do want to access some sort of training, depending on, and there's a broad spectrum of what that training could be. And so what we want to do is two things. One, increase the number of people who have had some skills development, who have that ability to, and inclination to want to be able to support people in various different communities in the way that I defined earlier, and also better connect them up together and to the opportunities where they can support people, communities and organisations. So I think that's the real crux of it. And I think what we found during the pandemic, for example, lots of people who wanted to take part in something, wanted to be able to volunteer, that weren't able to kind of access those opportunities. And then I think there's another element to this, which is around very often a lot of the training that's provided to support individuals to support others is contained in the place where they have received that training. So, for example, we deliver a really broad programme of work to young people who want to be mental health first aiders. That training is often, I suppose their perception is, once they're trained, is that they only have licence to use that training in that context. What we want to be able to do is to ensure people feel those are lifelong skills that then can be supported, they can be topped up, they can be refreshed over time, and that they feel that they are a community champion and that is part of themselves and they're able to take that forward. I think the kind of other element to this, so they will come from different routes, very often through building kind of community coalitions, community champions, the ways in which we're working with communities on a number of other elements. What we saw, for example, a good parallel, I'd say, is the vaccine programme. We had a huge army of hundreds of thousands of people that took part in volunteering for that. And that came from somewhere. So how do we harness a similar passion in people to be able to become a community wellbeing champion? And then kind of really working at that local level with local authorities and with neighbourhoods to look at how they're able to engage in activities locally. So we know that there's a lot of mobilisation of some of the community partnerships that exist to look at how they can work in the places most effectively to reach the people that need that sort of support. So at a local level, we're looking at 11 dimensions, if you like, of well-being that include income and wealth, work and job quality and security, housing, health itself, knowledge and skills, environment quality, and subjective well-being, safety and work-life balance. So I think there's kind of a whole range of different, I suppose, dimensions where we want to encourage the kind of role of those community champions and how they can engage in that. Really good example is we know some local areas are looking at how they can have people trained up as well-being champions who would then go and do some volunteering in job centres where people we know now an enormous swathe of people who are for the first time becoming unemployed and needing to needing to claim benefits. And so really being able to go to those places where people are struggling most is going to be kind of part of the plan.
And how many are there?
Well, the target is 250 wellbeing champions. We're based on, I mean, there are, and that's 250 people 250,000 people who are connected, who are part of a program, who have kind of an engagement collectively and together. Right now, for example, we probably have more than 200,000 Londoners who have completed suicide awareness training in the last 2 years. And actually what we don't have is a clear understanding of how well connected they are into some of the local opportunities to utilise that training.
I'm aware of the target of 250,000, but how many now?
So right now, let me try and, do we have...
So at the moment, we're collecting the data,
Yeah.
right? And so at the moment, we think we've got 65,000, but we want to clarify that data because that might include someone who's done a mental health first aid course and a suicide prevention course and a bereavement training course, all which we help and fund. So we don't want to count that person 3 times. So at the moment, we've got 65,000 people that we think match that definition, right? But I'm going to clarify that data and refine it. The figure will be lower than 65,000 because there will be some people who've done more than one of those courses that would make them, as Jazz's definition, a mental wellbeing champion.
Do they know they're mental wellbeing champions?
I would expect they do. Now, do I think they would define it just the way Jazz defined it? Probably not. But they would know they've done a training course. And also, the additionality which we are also trying to bring to it are 2 things. One is a hub of engagement, which is kind of like a way where people can access information and resource. The example being, I'm a mental wellbeing champion, I'm working with a neighbour, a work colleague, someone at the school gates, and they're depressed, they're anxious, and what do I do next? So they go onto the Thrive website and the hub of engagement. There is the Good Thinking website, which allows you to access anxiety management, depression management. Also, one thing as well we're doing, which I think is going to be spectacular, and that is, at the moment, if you want to access talking therapies in London, it's known as IAPT in general practice, Onca knows it, improving access to psychological therapies, you have to find a phone number, and you must even know what you're looking for. So we're going to use this process now of having a single place in London where you put in your postcode and your NHS resource for talking therapies comes up of how you contact them and how you get help. And we're going to make sure that all our wellbeing champions are aware of that. So when they're doing the work that they do, they will have the tools not just to listen and to support, but to actually do something about, giving additional access to mental health services that some of these Londoners will need.
So I mean, just help me understand this. So the 65,000, we're not talking about people who have been recruited. They are people who have done various training courses. And as a result of that, we've called them wellbeing champions.
So they are the ones who are likely to fit the definition. But what I don't want to do is kind of overpromise and underachieve. So that figure might be much lower, but I believe we will get our 250,000 wellbeing champions by our date. I think it's May 24.
I think it's 25.
Okay.
Actually,
thank
being
you.
generous to you. So we will be able to measure the progress.
Yeah.
Will we of that towards 250,000?
Definitely.
How will we do that?
Because we'll have a definition, and we'll then be able to assess whether how people are meeting that definition, and they'll be added onto our target. Again, the Health Equity Group, which Kevin chairs, has oversight of the whole process. But this is obviously part of one of our recovery missions, and that has a recovery mission group which is looking at that. and we'll make sure that we're calculating the data very carefully, making sure that the definition, is shared, is agreed upon, and that people qualify for it, and we can prove it. Because what one doesn't want, is us making spurious claims without being able to demonstrate to you real improvement.
Okay, and I think this program's. I think the idea of wellbeing champions is very important, and there are a few locally around here who take it on themselves to help people who are obviously under some mental pressure, and we're just trying to understand how this works, because is there a danger that if you centralise this, that it all falls to pieces?
That's why it's been led by Thrive. And one of the criticisms of Thrive when it first started, it was too dispersed. It was just embedded in the community. It didn't have a core programme office. But in fact, that was also the beauty of Thrive, because it was based in people's communities, in people's boroughs, in people's neighbourhood. So that's why we're using Thrive to be the key vehicle that we're going to use to develop this programme of work, just so it doesn't do what your fear is.
Yeah, it's a genuine fear. I've seen many London-wide schemes.
Quite right.
Sort of, the previous mayor had a very good intention on child mentoring, but I think it didn't quite get to where he wanted it to be, because I believe the model was over-centralised. But that's my opinion.
Can I just come in there? One thing which I think we've learned about the vaccine community champions and the COVID community champions is just what you just said. If you build these champions into your community, and Kevin talks about the hyper-local approach, only then do you get the 1,000 flowers that bloom. If you try, as we've done in the past, to push centrally things like vaccine programs, it doesn't always work, and it doesn't reach the people you want it to reach. I don't know, Kevin?
Yeah, and that certainly has been a lesson from the COVID champions and the COVID vaccine ambassadors, that it is actually building the asset within communities and learning from those lessons, but using your regional resource to facilitate learning and sharing of best and promising practice, and also to stimulate innovation. That's what we do at the regional level, but really the action should be as local as possible.
I mean, you've explained well what the objective of the wellbeing champions is, but will there be any particular disadvantaged groups that it's hoped the wellbeing champions will support?
So, because this is part of our health inequality strategy, so therefore, we will make sure it focuses where possible on those who face the most inequalities, which is, in mental health terms, it's very much about people with disability, our LGBTQ community, black and minority ethnic community, and often our recently arrived migrants and those who are rough sleepers. So therefore, I would want to make sure that when we're focusing this work, it does what it's meant to do, is address health inequalities. Especially, and we do know that those communities suffer the most poorest mental health, or more likely to kill themselves. And therefore, this project has to address those two outcomes: poor mental health and suicide.
Can I just add there, I think there's kind of two key programmes within the approach. So Right to Thrive is an element of the programme that's really going to focus in on intersectional marginalised communities, and really kind of provide a grant scheme, a small grant scheme that will kind of support community organisations who really work in that sort of space with those communities. And kind of complementary to that is a programme around resilience, to look at how, through the Thrive London champions and mental health sector partners work, looking at how they can kind of, through their peer support, so it's a peer support scheme, how particularly mental health champions, wellbeing champions who are from those communities can be kind of better buddied up, have a bit more of a peer support that will enable their their offer, if you like, as champions to be far more impactful in communities. So that's kind of two very specific things. Then there's the wider work around tackling groups with greater risk of mental illness, including obviously those communities that we've talked about. But we know, for example, men's mental health has significantly kind of greater challenges. So some of the Men's Health Week work, some of the wider programs that we're delivering, if you like, slightly beyond the specific deliverables for the Champions programme, but are still constitute part of our agreement and work with through Thrive London, will also be additionally supportive to this to that objective. And then there's kind of work that other partners are doing that will also contribute to almost the kind of the ballast, if you like, that sits underneath and behind the objective around the Champions work. So OHID's work, so Kevin's team doing the work around prevention and promotion of the kind of Fund for Better Mental Health. Will support 11 London boroughs to develop prevention-focused approaches to improving mental health in their communities. The work that the ICSs will be doing on mental health trusts to look at how there's greater relationships directly with mental health trusts, and particularly, for example, where champions might identify people, actually their problem is they're not getting the right access to services, so enabling some of that, bridging some of those sorts of challenges, and actually looking at how we can get better access and better utility of the NHS data sets on mental health and mental illness, and then looking at how working with them and extending and continuing some of the work that actually we'd funded through the pandemic. So during the pandemic, we funded Good Thinking, which is a digital access tool to provide specific kind of access for younger people. So it was a model that was kind of provided more generically, I suppose, and we asked that work, so we funded it to focus in on supporting younger Londoners. And then through some of the London Borough of Culture's work, and we're doing some work directly with Lewisham and next year with Croydon, to look at how they would have a bit of a theme around wellbeing and utilise the champions that are kind of, I suppose, created in those communities to really kind of tie into some of those work. So I suppose what we've got an opportunity here is to have greater support of the wellbeing champions, and the champions having a much broader kind of role across some of that wider, more strategic way of working in those local places.
Can I just ask, and you'd be pleased to know this is my last question. I just wanted to ask, last week we approved the Mayor's budget, and that actually halved the amount, more than halved the amount available to the health and wellbeing missions budget. How is that going to affect the rollout of the Mayor's ambition?
So the budget for the mental health and wellbeing block, if you like, so there are 3 health budgets that sit within the kind of the overall budget for the GLA. The mental health and wellbeing block previously included quite a lot of activity that wasn't directly related specifically to the mental health and wellbeing, not just the mission, but that broader kind of description that I've given you. So what we needed to do is to recalibrate how budget had been allocated across to all 3 blocks, and which, for example, included funding for some other areas of work, delivery of other aspects of the health inequality strategy, for example, or work that we would be doing through kind of focused in our policy work on health and care partnerships, or even funding staff. So what we've done is recalibrate the budget so it already wasn't quite right. So now the budget, as it currently stands, is correct for what we will be delivering across what I've described.
And is that about £700,000?
Yes.
And will there be any external funding?
Yes. So the point is, the budget that we have allocated is our contribution to a partnership approach to delivering the mission.
And who are the partners, and how much are they paying?
So we'll come back to you on that. I think that's part of a kind of a broader approach. So what I've described, there's some specific work that will fund the support of creation and the networking and the hubs for the wellbeing champions. That money is contained here. So that's £450,000. So that's what that will be per year, specifically for the programmes of work that will create and support the champions. And that is what we've calculated, and that is the money that we think we need to invest in that programme. Additional money from partners will be in support of that. So the way I described, there's a wider opportunity to make sure that we are providing that ballast and wider support, and then where those champions can more broadly work. that is where some of that wider money
we must have somebody in mind as to who the partners are going to be.
Yeah, so the other partners will be local authorities, the voluntary sector itself, the NHS, and actually what we're also looking at is the wider business sector. So, for example, we've already had conversations with colleagues who are leading on the High Streets mission, who are really keen to look at how we can place some of these and support them to be in places where, on high streets, where they know that there's kind of opportunities to really support well-being. So they kind of, there's lots of creative thinking.
Andrew, to give you an example, so many businesses now see the benefit of doing mental health first aid training for their employees. They realise that you're much more likely to not go to work because you've got poor mental health rather than poor physical health. So they themselves are investing in putting their employees on mental health first aid training, and that is an investment which will go to creating these wellbeing champions. Secondly, the King's Fund looked for us at the health service in London, and they gave us a report which came out last year. And the key message it came through said that the NHS has now adopted the City Hall's approach where health inequality is integral to all that they deliver. And now the new 5 ICSs have as part of one of their top priorities addressing health inequalities and doing our work that we've described to you today with their money.
So Professor Fenton, are the NHS going to come up with some support for this scheme?
I can't speak for the NHS as I'm not with the NHS, but I would certainly be advocating for as many of our health and care partners to be investing and supporting this important initiative. Absolutely.
Great. Thank you very much. Thank you, Chair.
Thank you, and thank you everyone to all three of our guests for a really illuminating afternoon. It's a hugely ambitious programme to put health in all policies, and I think the sort of it's been just really helpful for us to have the opportunity to ask some of our very basic questions, but trying to really understand exactly how this new way of working is going to work. It certainly sounds there's all the stuff about learning the lessons from the pandemic and the ways that we found to work differently during that, working with the model of the sort of vaccine volunteers. That's been a very inspiring thing to see and witness as we've gone through this last 2 years. I think it's also exposed that there's bits that are still unclear about exactly how they're going to work, and we will obviously want to keep in close contact as all of those details become more scoped out and more defined. And but I think we do have a much clearer idea of what we're trying to track and watch as this work progresses. So thank you very much, all of you, for your time. Now, I just very briefly need to ask the committee to note the report and the subsequent discussion.
Noted.
Thank you. Delegate authority to me as chair in consultation with the party group lead members to agree any output from this discussion.
Agreed.
Thank you. The next meeting of the committee will be confirmed at the London Assembly's annual meeting on the 6th of May 2022. There are no items of urgent business, so I declare this meeting closed. Thank you very much.